Well, good morning and welcome to Life Beyond the Basics 2025 PCLA's annual educational conference. I'm Patrick Lasasso, president of Parkinson's Community Los Angeles, and I am so excited for today's unique presentation. But first, on behalf of PCLA, I'd like to thank our partner, Acadia, who helped make today possible, as well as all of you in our community who donate to help sustain PCLA and our mission. If you enjoyed today's presentation, please consider donating. There should be a QR code on your screen, but if there's not, you can simply visit pcla.org and click the donate button. So a few months ago, our planning committee was discussing what today's theme would be. Two concepts emerged. We all perceived a yearning for our community to cultivate and nurture hope and to experience joy. Some of you know that I have two lovely 10-year-old twin girls, Kate and May, who've been coming to our events pretty much since birth. And after our planning meeting, I was sharing the committee's theme of nurturing hope and joy with my daughter, Kate, when she remarked, "It sounds like a garden." And I thought, well, we're not going to top that. So we really owe credit for today's name and theme to a 10-year-old. Today's 2025 Life Beyond the Basics is titled The Garden, Cultivating and Nurturing a Life with Joy. We've asked our six speakers, who are experts from PCLA's very own medical advisory board, to incorporate into their presentations the metaphor of nurturing life's garden. Our desire is that you'll leave today with a perspective that allows for a little more hope and a little more joy, despite a Parkinson's diagnosis. We are recording today's presentation, and it will be posted to PCLA's YouTube channel, which, if you don't know about, has some amazing content. You will all receive a shareable link via email as soon as today's program is available. Today is a celebration of PCLA's thriving mission to empower lives impacted by Parkinson's by providing resources, strategies, and cultivating relationships, inspiring you to live your absolute best life. I'd like to thank our hardworking PCLA board and our community engagement director, Natalie Holtzman, and our information and referral specialist, Charles Scheel. You are all so dedicated and amazing. So thank you, thank you. So without further ado, let's move on to our first presentation. Please welcome gastroenterologist, Dr. Wael El-Nachef with Huntington Hospital.
Good morning, everyone. Always a pleasure to give talks to this group. I think PCLA does, a great job with this community, and I'm proud to be a part of it too. I think the microbiome fits well with this idea of cultivating a garden. I've given similar talks in the past, and I'm going to try to focus on some of the updates in the last year or so on what's been done on this topic with regards to Parkinson's disease. And so first I'll start by saying I'm a gastroenterologist, not a neurologist, but what's really interesting about Parkinson's disease, which many of you may be aware of, is that it can also affect every part of the GI tract from top to bottom. You can have difficulty swallowing, due to your esophagus. Your stomach can move slowly. We call that gastroparesis. Your small intestine can get involved and lead to something called small intestinal bacterial overgrowth, and most commonly constipation, and a related issue where it's difficult to pass stool called dysenergic defecation. Now, what's really interesting about the GI symptoms in Parkinson's is that these can predate the diagnosis of Parkinson's by many years, if not decades. And so here you can see a lot of the more classic motor symptoms and their relationship to when the diagnosis of Parkinson's is made. But constipation can precede this by many years. And so there's an idea that perhaps Parkinson's disease may spread in the gut, at least in a subset of patients. And the actual misfolded protein called Lewy bodies can be found in both the brain and also in the nerve cells of the gut. And, a lot of people might not be aware, but there are as many nerve cells in your gut as there are in your spinal cord. And we call this the second brain because of that. And what you're looking at here is the different layers of the intestine and sandwiched between the layers are just it's chock full of nerve cells and nerve endings. And so, the gut is the second largest neurologic organ in your body. Now, we talk a lot about the gut-brain connection, and I think sometimes people might lose sight of when we say the gut-brain connection, literally, like physically, there is a connection. There are major nerves that connect your brain and your central nervous system to your gut. They're physically connected. And so, for this idea for Parkinson's to start in the gut and spread to the brain, or vice versa, like that makes a lot of sense. There's a lot of data, in animal studies, and even there's some supportive data in humans to support that. Now, how does, so I mentioned that the gut is the second largest neurological organ, but it's not just a tube. It's essentially a metabolic reactor. And what really drives this is a ton of bacteria throughout the GI tract, from, mostly in our small intestines and colons. And this, didn't happen overnight. This is something that has co-evolved with humans over like thousands of years. And some of the interesting factoids are there are more gut cells, the bacterial cells in your gut than there are human cells in your body. And so these bacteria, they don't live, in our guts rent-free. They're providing us metabolites. They're providing us things that we need to live. And this really has a big impact. And if you didn't have bacteria in your gut, you would be unwell. So these are not an infection. This is a symbiotic relationship. But if this balance of bacteria is off, if the wrong bacteria are there, then you can have bad outcomes, like you can have symptoms, you can have illnesses. And when this balance of bacteria is off, the term is called dysbiosis. Now in Parkinson's, this is where we have shown many times that balance of bacteria is not what you would see in the average person. That dysbiosis is very common in Parkinson's. But the question is which direction does this relationship go? Is the dysbiosis in our guts, is that the cause of Parkinson's? Or is Parkinson's messing up the function of the GI tract, and that in turn is causing the dysbiosis? Is it the other way around? That's a side effect of Parkinson's. Or this is a more recent study, is the dysbiosis affecting absorption and metabolism of Parkinson's drugs like carbidopa, levodopa? And there have been studies that have shown that. So these are open questions still, and we're still investigating that. And so a lot of the really exciting research that came out in recent years showing in Parkinson's in a mouse model in a lab doesn't translate. So I'm going to go through different approaches to manipulating the bacteria in our guts. The first idea is replacing the bacteria you have with new bacteria. And so we call this fecal microbial transplant, or like the stool transplant. And essentially, you get a donor to provide stool, and you apply that. It can be through different modalities. It can be applied via colonoscopy, through capsules, through enemas, and you're essentially replacing the bacteria that are in your colon or your intestine with a donor's bacteria. And in some situations, they'll even give you antibiotics first to clear out what bacteria you already have. And this is already clinically approved, like by the FDA, for certain types of infections of the gut. There's early studies to look at its application to other diseases like inflammatory bowel disease and many other diseases, in fact. But ultimately, we're interested in Parkinson's. And so there have been a number of different small trials in Parkinson's for fecal microbial transplant. And when they're doing these studies, they're usually looking at, does this improve GI function? And does this improve motor symptoms of Parkinson's? So the first trial, again, all these studies are very small. I think this one came out in 2023, and the FMT was given as oral capsules. And essentially they showed that it was, first of all of these studies have shown that it's safe. Like there were no serious side effects from doing this. They did show that dysbiosis was improved in patients with Parkinson's. but didn't really seem to show any improvement in the motor symptoms. And but they might have improved some of the GI function. But it was kind of a weak study, if you're asking me. Like, I wasn't wowed by this. A second study came out, um, again, pretty small, only 22 patients that were treated. And again, they were safe. And this study actually showed some motor symptom improvement. And this is like just beyond what we call clinically relevant or meaningful. And so this is not, again, not a wow factor. This is not, a life-changing alteration. And again, they didn't show any huge improvements in GI benefits. And then the last study, I think this was from Finland, and this is probably the most recent one. Again, a relatively small study. And then you can see like each of these studies use different protocols. So in this study, they gave the transplant via colonoscopy. And they did not show really any significant impact on motor symptoms. And, so for me, there's a lot of heterogeneity, a lot of mixed results here. And, I think there's a lot of hope for FMT, but, what we have so far is still telling us that there's more work to be done. Of note, very recently, a study at UCSF concluded its trial, and they're writing up the results. So we're still waiting for that, and we'll see if maybe they have the right cocktail, the right approach, the right protocol to get some more meaningful results. There was a meta-analysis, meaning someone took the studies that have all been done, combined all the data to try to get some overall conclusion, and they basically have the same perception that I'm having, that we need bigger trials, more than just like a dozen or 2 dozen patients in each arm, and that we need to standardize the approach so it's easier to compare and figure out what works. And one of the concerning things I noticed is that the number of clinical trials for fecal microbial transplant, FMT, has decreased over the years. I think there was 8 planned, and now the ones that are pending, there's more like 6. And so my attitude is this is not ready for prime time, but it's something to keep our eyes on, and hopefully someone figures out the right approach to this. I want to make sure I'm doing okay on time. Now, I mentioned fecal microbial transplant was about replacing bacteria. What about just removing bacteria, with antibiotics? And so there have been some studies to show that a common bacteria that infects the stomach called Helicobacter pylori, or H. pylori, has been associated with worsening Parkinson symptoms. And there have been some small trials to show that if you treat the H. pylori, motor symptoms could get better. But again, it's mixed results. Ultimately, if you have H. pylori, you should get it treated for many other reasons. So I think it's worth, if you have upper GI symptoms, it's worth getting tested and treated if you have H. More commonly known is the SIBO, or small intestinal bacterial overgrowth. Now, this is not an infection. This is just too much bacteria that should be there. And having too many bacteria can cause symptoms. If you have a specific version of SIBO, it can cause more diarrhea type symptoms and bloating. And another version of SIBO can cause more constipation. And that version is more common in Parkinson's. It's a methane producing bacteria that is responsible for that. My approach to this is that is that in Parkinson's, I think this is more likely due to the intestine moving slowly rather than just a purely bacteria issue. It's because the intestine is moving slowly that bacteria can overpopulate. And if you treat, the motility issue, oftentimes the bacteria issue gets better. And I usually only pursue breath testing and treatment for SIBO if all the other things I do don't work. I don't start with breath testing. That's been a major change of mine over the past couple of years. There's a recent trial of SIBO and Parkinson's disease that got completed recently, but we're waiting for those results to be published. They were actually presented at a meeting. I didn't have access to those results, but I'm interested to see how that pans out. But previous studies have shown that if you treat the SIBO and Parkinson's, but don't treat the dysmotility, that the SIBO just comes back after 6 months or so. So another approach that comes up is not replacing, not removing, but adding good bacteria in the form of probiotics. And so this is where like a lot of patients ask me about this all the time. And I think the issue is there's a lot of studies out there, a lot of studies. And so people might find one study that looks good and they'll bring it to me even. They'll print it out and say, look, but the truth is there's so many studies, a lot of them aren't done well. So when we do a meta-analysis, you combine all the studies together and review all the available data and sort of put it together in a melting pot and say, okay, what comes out? When I last gave this talk, there was a meta-analysis from 2022, and they said there was not enough evidence to support it. But very recently, another meta-analysis was completed that had updated information. And now it's saying there's possible improvement in constipation with probiotics, but not motor symptoms. But also the evidence was sort of, soft, and it was all the studies use different strains. And so it's difficult for me to make recommendations, like hard recommendations in support of probiotics. So I'm not, because people ask me which one should I use, which strain is the right one. The studies are all over the map. And so part of the problem too is probiotics are generally not FDA regulated. And so it's unclear what you're actually getting anyway. And so I don't think it hurts. If you want to try a probiotic, go for it. But if you don't notice an improvement after a couple of weeks, stop taking them. Because I have patients who've been taking probiotics for months or years, and they've noticed no improvement. And I said, why do you keep taking them? Just stop. My alternative recommendation is to instead eat foods that naturally have probiotics in them. And some of these foods are things that, I like, yogurt, kefir, but also things like kimchi, sauerkraut, etc. So you can look into, dietary changes that can naturally enhance your probiotic intake. And then there's this concept called prebiotics. And so prebiotics are essentially foods that you eat that favor the good bacteria in your gut. And so we've been saying this for a long time, eat prebiotics. These are essentially like fruits and vegetables, foods that have fiber in them. But very recently, a study came out that gave a little bit of more of a science oomph to what we say, and they showed that prebiotics increase the short chain fatty acid production of the microbiome bacteria in your gut. And short chain fatty acids are shown to be anti-inflammatory, and they have neurological benefits potentially in strengthening the blood-brain barrier. Again, this is very early days. This is not something that I would say is proven, but number one, the data is suggestive, and number two, eating prebiotics is good for you, even if you don't have Parkinson's. Like, this is what everybody should be eating anyway. But I think there's extra reason to eat prebiotic foods. And then a very hot off the press study too looked at the oral microbiome. So when we say microbiome, we're often referring specifically to the microbiome in the GI tract, but your mouth has a microbiome too. And a study that was looking at Parkinson's patients and looking at the microbiome of their mouth found that there were certain patterns of bacteria that were associated with worse cognitive function and an impairment over time. And so the idea here, first of all, this again, a very early stage. This is more of hypothesis generating research. We're saying there's an association, but it hasn't been proven as causation. But at the end of the day, this would just make me encourage people to be on top of their dental hygiene, and if they have salivary dysfunction, to get help with that, because that could potentially help with their gut microbiome with some of these other issues. And you should be doing these things anyway. But just to underline it, to underscore it. So some key takeaways from this, I think we don't want to take the relationship of the microbiome and Parkinson's as a foregone conclusion. I think it's very compelling. I think it's very interesting. And I think there's a lot of research that can be done. And there's many different ways to try to target and adjust the microbiome to modulate it. None of these are fully proven yet, but there's growing evidence to support that, there's things we can do to help our microbiome that could have benefit for us. But at the same time, if you're having GI issues and you have Parkinson's, don't just, don't pin all your hopes on the microbiome, waiting for fecal microbial transplant to be FDA approved. I think there's things we can do today with or without the microbiome, like other medications, other approaches that can help with your symptoms. So don't just, wait for a microbiome treatment to come out for the masses. And of course, I say this in every talk, whether you have Parkinson's or you're a family member, make sure your colon cancer screening is up to date. It's one of the most common cancers. So please make sure that's up to date. But that's it for my talk. I think we're good on time. Happy to
Thank
take
you.
any questions.
Thank you, Dr. El-Nachef. We have a few questions here. One from Luis Torres is there evidence that the efficacy of the carbidopa-levodopa is affected or diminished?
Yeah. So my understanding is that there's uh, more like laboratory style research, not necessarily in humans, that have shown that the bacteria that are common in Parkinson's patients can break down the drugs that like carbidopa levodopa too quickly and affect the amounts that actually reach your body. And so yeah, so that's it was a very well done study. It was very compelling, and that's something that we have to consider. But exactly how do you approach that? No one's I haven't seen any of these studies saying we should give antibiotics to improve carbidopa levodopa dosing. But it's an interesting concept. But yeah, that might be one of the hurdles we faced when treating Parkinson's.
Is there a specific protocol for gastroparesis?
So what I do, so first of all, I think when we talk about gastroparesis, I think it's important to be very specific for Parkinson's disease and gastroparesis, because I've had patients who go to the ER with symptoms of gastroparesis, and they're given a medicine called metoclopramide or Reglan, and that is like not a good idea if you have Parkinson's. I don't think every physician knows this, and so that's like Reglan or metoclopramide for general people is a treatment for gastroparesis. It speeds up your stomach, but in Parkinson's, it can make your Parkinson's worse. So I often tell my patients to list Reglan as an allergy, as a drug allergy, even if it's not a true allergy, just so that it's in your chart and no doctor can give it to you. But going back to the question, is my approach to gastroparesis in Parkinson's is a different medication called prucalopride. The brand name is Motegrity. It went off patent recently, thank God. So it should be more accessible to everybody. But this medicine is approved for constipation by speeding up the colon, but it actually speeds up the entire GI tract from top to bottom and includes the stomach. So many of my patients with gastroparesis and Parkinson's who get prucalopride have benefits to their gastroparesis with that medication and do well.
We've had some people in support groups ask if their Parkinson's really starts in the gut. And I know there's been some theories about this, where it might be starting. Do you have some ideas about this?
Yeah, so I mean, I think there's a growing literature, a growing research on this, and there's the gut first hypothesis. And I think, I'd make the analogy to like heart failure. Like, many years ago, there was just one type of heart failure. You had heart failure because you had the swollen legs and you had shortness of breath, maybe some chest pain. But as we learned more about heart failure, there was heart failure because of, prior heart attacks and scar tissue, heart failure because the muscles were too thick from long-term high blood pressure, heart failure because it was dilated, etc. And so, even though all the manifestations were the same, the underlying causes were different and just, look the same. I think with Parkinson's, what we're seeing, what we're diagnosing is based on the manifestations of like motor symptoms and other issues. But we're learning more that maybe this is Parkinson's gut first, or Parkinson's brain first, or Parkinson's, peripheral nervous system first. And I have a feeling that there's going to be different flavors of Parkinson's that will be diagnosed in the future as part of routine clinical care. And my feeling is based on patients I talk to, about a third of them have their GI symptoms years before they have the Parkinson's, and they're probably the gut first people. And about a third of them are after they've been diagnosed. then they develop the GI symptoms later. And about a third of them have the GI symptoms and the motor symptoms around the same time, within a year or two. So I think that's, like, from my experience, how it breaks down. But I'm curious to see how the research pans out, but I think that's where we're headed.
We've got another question in the chat here. There is much information about types of food or diet we should follow to improve gut issues. Is there anyone in particular that is better than others? Thank you, Louis.
So in terms of the foods, like that can be a whole topic in and of itself. I think I'll often give like some pretty general recommendations to my patients in clinic, but I also frequently will refer them to GI dietitians, and not just dietitians in general. I'm sure there's very many good general dietitians out there, but I think when we're dealing with like this sort of very specialized sort of question about gut diet for the GI tract in Parkinson's, I've had really good experiences working with the GI dietitians at UCLA, where I used to do research. And so I continue to work with them pretty closely on a lot of patients, and they do a really great job with everybody. But that being said, I think again, talking about prebiotics, like just fruits and veggies, try to have at least a serving with every meal. Like that's a good starting point. Oftentimes people will throw how many grams you're supposed to eat per day. That's hard to translate into real life, at least in the beginning. But just trying to eat fruits and veggies with each meal, avoiding foods that set off or trigger symptoms, and just trying to be mindful of keeping track of what that might be. So trying to be systematic, if you're very sensitive to different foods that you eat. And then lastly, I think mistake some patients might make is they hear fiber is good for me, and they get Metamucil and they take like 10 doses a day, and that can cause a lot of side effects with bloating, etc. And I would say whatever you make a change like that, go gradual. But I think that's a whole nother conversation too, this idea of diet.
Okay, thank you. We had Elizabeth Moore asked if you could spell the medicine that speeds up the gut
Yeah,
for constipation.
yeah. So the branded name is Motegrity. It's M as in Mary, O as in octopus, T as in Tom, E as in elephant, G as in girl, R as in Robert, I as in igloo, T as in Tom, Y as in yellow. I think I spelled it right. And then that's a branded name. I'm not endorsing the branded name. Prucalopride. I won't spell it out this time, but you'll find it if you Google Integrity. But
Right,
essentially, that's the medication.
right. And the medication is Integrity that you said not to use.
The one not to use.
Oh, wait, no. What was the medication not to use?
Oh, the
The for
medication
the
not
gut,
to. No,
she's asking.
Motegrity is the
Oh,
one you should use. Just to be clear.
Integrity is the one you should use.
Yeah,
Okay,
sorry. Reglan is the branded name, and that one's
okay.
much easier to spell. So Reglan is in Nancy, and just put that on your allergy list. And maybe someone will say that's not good. I'm telling you, just do it, because getting that medication could make you miserable if you have Parkinson's.
Also, we would love to have the referrals for the gastro dietitians. I think that's great. I haven't heard about them. So,
Yeah, absolutely. I mean, if you Google GI dietitian UCLA, they have their own webpage, and that's usually what I refer my patients to. It has their phone number and ways to contact them. And so I think any of those people there are excellent. And I think I'm just like I would say be cautious. Like you can go outside of UCLA, that's fine, but just be cautious of if someone's trying to sell you a lot of supplements. And I think try to focus on evidence-based recommendations. So because you can go down a real rabbit hole sometimes in that department.
That's a very important note that I like to reinforce, that be very careful where you're getting your information from. And there's a lot of predatory forces out there promising false cures and things that help that haven't really been scientifically validated. So I always recommend people check things out with their medical team first. Okay, well, thank you so much, Dr. Wael.
Thank you very much.
Really appreciate your time as always. What a wonderful presentation. And this is what they do for clapping, I think. And we're going to give you a big one. Applause.
Thank you, everybody.
Okay.
love it. Thank you.
Bye-bye.
Okay. Please give a warm welcome to Dr. Melita Petrossian, neurologist and MDS. Melita is the medical director of the Movement Disorder Center at Providence St. John's Health, and she's going to be discussing new treatments, cultivating positivity and hope within your Parkinson's space, and what we can look forward to down the line. Thank you, Melita.
Thank you, Patrick. Thank you, Judy. So yesterday I saw Judy and a number of other people at the Dancing Through Parkinson's event, and it was, as always, very inspiring to see people cultivating joy and really, putting themselves out there in a wonderful way. So I was really inspired by that and by everything that you all do, including the team at PCLA, but all the people on the line. So I really appreciate everybody joining us here today. So the good news is that there's so much to talk about as far as new treatments that the bad news is that I'm not going to get to everything. And also because I'm going to need to kind of just explain some things before I can go into what these new treatments mean and what they entail. So bear with me and I'll have to go quickly. So please bear with me. And sorry, I'm just going to figure out why this isn't going forward. We'll go that way. Okay. So we'll talk about symptomatic treatments and preventative treatments subsequently. So symptomatic treatments refer to treating just the symptoms of the condition. But really specifically, we're only talking about treating motor symptoms today. And those are slowness, stiffness, rest tremor, shuffling, etc. And these are caused by low dopamine levels due to loss of dopamine neurons in the brain and are generally improved with levodopa, which gets converted into dopamine. This is completely unrelated to the management of non-motor symptoms, which is, of course, also extremely important. So when people sometimes ask, well, I'm taking all these Parkinson's meds and my, constipation, for example, isn't getting better. It's because really there's a limit to what levodopa can do. Quite a large percentage of people with Parkinson's note an initial significant improvement with levodopa, but subsequently, as the years go by, the accessibility and the duration of the benefit changes. So initially on the left, you will have patients taking levodopa 3 times a day, and their symptoms improve as the dose kicks in. And as the dose wears off, they don't necessarily notice any differences because they're still remaining in this well-controlled state with improvements in slowness, stiffness, tremor, etc. As the years go by, they may transition to kind of the right side of the screen, where as the dose kicks in, it takes longer for it to kick in. They spend a shorter amount of time in what's considered on, meaning symptoms are well controlled, and they may experience dyskinesias, which are involuntary movements. And then as the medication wears off, they spend more time off before they're due for their next dose and while they're waiting for that dose to kick in. So they have more of a roller coaster ride of on with dyskinesias, off where they're feeling slow, stiff, stuck. Now, this is different from just having an off day or just having a bad day because you didn't sleep well last night or you're anxious. It really is specific to how long are these medications lasting. These are known as motor complications or motor fluctuations. Levodopa, of course, is not the only thing that we use to treat Parkinson's for motor symptom control. Levodopa gets converted in the brain into dopamine, and it comes in many forms, which we'll discuss. The most common of which is the brand name Cinnamon, which nobody calls it that anymore, but it's faster and easier to say than carbidopa levodopa. But then the dopamine within the brain has to work on dopamine receptors. So the analogy I like to give here is keys and locks. So the dopamine is the key, the dopamine receptor is the lock. The key needs to go into the lock to open the cascade of better improved movement. But there are dopamine agonists that can work on the same receptors that would be considered like a different key working on the same lock. And that includes pramipexole, ropinirole, rotigotine, and apomorphine. Apomorphine has nothing to do with morphine, it should be noted. Then, of course, there are ways to break down the ways to reduce the metabolism or the breakdown of dopamine. Those are the MAOB inhibitors, and the COMT inhibitors actually work only on levodopa itself. So the point is that there's different ways of boosting dopamine in the brain. In the past decade or so, there's been several new motor medications, FDA approved and available for use in the United States. And so I won't go too far into the ones from 2014 to 2018, but we'll focus more on the more recent, especially in the last few years. So primarily, we can discuss longer acting forms of levodopa. Of course, Rytary was in 2014, and then a decade later, Crexont. They're actually made by the same company. These are capsule forms of levodopa, and they're essentially extended release forms where the Rytary includes microbeads of immediate and controlled release, whereas the Crexont includes a kind of like a scaffolding of an outer shell of immediate release, then an inner part of controlled release, and then a gel core that adheres to the small intestine to increase the availability of the levodopa to get absorbed through the gut. So you can see that compared to immediate release, especially on the right here, there's a longer lasting efficacy. For patients where the gut is really a challenging place to absorb the levodopa and they're still having unpredictable off time, there is an inhalable form of levodopa called Inbrija that was FDA approved in 2019. So this is not in lieu of oral forms of levodopa. This is as a rescue drug for times where that medication wore off earlier than expected, or it will take too long for it to kick in. So it doesn't last very long, 1 to 4 hours, but it does kick in faster, like 5 to 15 minutes. And again, it bypasses the gut because it gets inhaled through the lungs. So it works well in those issues of, sometimes when people are taking their medication very frequently, it's hard to take it on an empty stomach. Of course, taking levodopa on an empty stomach makes it absorb more fully, but that can be very difficult and challenging in the real world to always take your medication on an empty stomach. So again, because this is just a rescue drug, it doesn't prevent off time. It's just a way to manage it, to bridge to that next oral dose. And of course, the side effects can include coughing and upper respiratory symptoms, but taking slower breaths, trying it a few times, drinking water before and after can help. As with all of the medications we're going to be discussing today, I want to put a reminder out there that not everything works 100% of the time for 100% of the people, but there are definitely people who have been improved with all of these later advances in motor symptom control. So an older infusion of levodopa was available beginning in 2015, but didn't have a huge usage, I would say, in the United States because it required the placement of essentially a feeding tube, which wasn't being used for food. It was just being used for medication called a PEJ tube. And this medication is called Duopa. In Europe, it was called Duodopa. But it is the same carbidopa levodopa, but it does get infused into the intestine directly. It reduces off time about 2 hours compared to oral dosing, bypassing the stomach. But because it is a feeding tube, complications can include tube malfunction, slowed gut, people pulling out the tube, and neuropathy. And this is on the right what that system looked like. More recently, specifically last year, a infusion form of carbidopa levodopa was FDA approved called Wael. And that is the FOS here, carbidopa, levodopa means they're precursor drugs that get converted into dopamine. This on the right is a picture of a person using this medication where he has a pump worn externally at the hip. a plastic tubing that connects to a plastic catheter that goes into the skin for a subcutaneous infusion lasting up to 24 hours per day. There's no needle that goes into the skin. It's just a plastic catheter. And these are applied directly by the patient or the patient's family member at home after training by a nurse. Vyalev improves on time and reduces off time about 2 hours compared to oral levodopa. Risks include infusion site reactions or infections and hallucinations. The discontinuation rate is about 22%, mostly in the first 10 weeks. In the case of both Duopa, and Vyalev, all of the oral levodopa is stopped. So this is a conversion of all of those oral doses to just this pump form. And the patient is able to give themselves booster doses as needed according to the settings placed by the physician. People have asked me about this because there was a study a few months ago about this weekly form of levodopa. And, as with a lot of medical reporting, the, statement from the headline was like, it's new and it's out there. And it's not out there, it's just new, meaning that this was a proof of concept publication in a drug journal. And they studied it in vitro, meaning like in cells, and actually not even in cells, in like in vitro literally means in glass. And then they put it into pig muscle, like not like even like living animal trials. So it's still very, very, very early, but was really kind of a promising concept that they could create this implant that would release the carbidopa levodopa over 7 days. So really still very early, has to be seen if it can go into human trials and then go into human clinical trials. But people have been asking me about that, so I mentioned it here. So that's far from getting FDA approved. Getting back to what is FDA approved already, apomorphine infusion, again, as a reminder, it has nothing to do with morphine. It's not an opiate, but it is a very effective dopamine agonist. So dopamine agonists, as I mentioned, work on the motor symptoms of Parkinson's separately or sort of differently from levodopa. Using this infusion, again, up to 24-hour infusion, for some patients, they preferred not to wear it overnight. They don't have to wear this overnight. Was able to reduce off time and improve on time by 2 hours compared to placebo. And patients had a 15% average reduction in levodopa dose. About a third of patients were able to stop at least one Parkinson's med, but about 11% of patients discontinued due to side effects, and there was risk of infusion site nodules or reactions, nausea, sleepiness, dyskinesias, and headache. And this is a diagram of how it's connected, applied, and infused, and it's very similar to the Vyalev in that it's a pump that's worn externally, the tubing, and then a plastic catheter going into the skin that's self-applied at home after training with a nurse. This would not be in lieu of oral levodopa, but as I mentioned, it would often result in a reduction in dose. There is a different dopamine agonist that's in the pipeline, not yet FDA approved, but seemingly close to FDA approval because it's already shown positive phase 3 trials. And interestingly, this dopamine agonist, tavapadon, which works differently from traditional dopamine agonists, was studied not only in advanced stages, or I guess I would say moderate stages of Parkinson's with motor fluctuations, but also in early Parkinson's patients. It works on the D1, D5 receptor. So there are subtypes of dopamine receptors, and the traditional, that is to say, older dopamine agonists, ropinirole, pramipexole, and rotigotine work on D2 and D3, whereas this one works on D1, D5. So the concept is that it would have more specificity for motor improvement with a lower risk of impulse control disorders. I'm sorry, I wrote disease, but I meant disorder, hallucinations, and sleepiness, which is a really big concern with ropinirole and pramipexole, and also to a lesser extent rotigotine. Epimorphine has broad spectrum effects across D1 and D through D5, but tavapadon is not yet FDA approved. The trials in patients who were not on levodopa showed with monotherapy, meaning only taking tavapadon, they improved their motor scores by 4 or 5 points on average. There were mild side effects of nausea, headache, and dizziness. It was really, I think, helpful to know that it requires only once daily dosing. And for a lot of patients who are in early stages of Parkinson's, not yet on levodopa, and they're not keen on starting levodopa just yet, this may prove to be a good way to potentially delay starting levodopa. In those who are on levodopa with motor fluctuations, it improved off time by about an hour compared to placebo. So the word is that they were planning to submit to the FDA in 2025. We're already in September, and there hasn't been any updated press releases about this, but I'm hopeful that this will come to pass maybe next year. So moving away from medications for motor symptoms, we'll talk about deep brain stimulation. So DBS has been around since 1997, actually. It is a deep brain stimulation pacemaker for the brain, allowing the efficacy of the medication to last longer during the day, only treating motor symptoms of Parkinson's, again, as we discussed earlier, tremor, slowness, stiffness, and off time dyskinesias. Requires the implantation of hardware in the brain. What's new is this concept of adaptive DBS. So the image on the left is how DBS had been up until literally this year. There was an evaluation by the neurologist, a programming session, manual adjustment of the stimulation parameters, and then stimulation, meaning that that was the only feedback that we really had. And the also key point there is that the stimulation, once it was set, was always on at the setting that was placed by the doctor with, or nurse practitioner, with the ability to go up and down manually by the patient if the physician gave that capacity to the patient programmer. But that would only be like tweaking up and down by a small amount. And that would be a manual, like I have to go in to do this and then see what it does. The right side of the screen shows you what adaptive DBS does. So in addition to the evaluation by the neurologist, there's also a sensor that measures brain signals, and then that signals to the programmer to adjust the stimulator. I won't say on and off. I would say up and down. We're not really going on and off because I think that would just be too harsh on patients. We're really just ramping up and down on the stimulation so that we're getting feedback from the brain to properly decide how much stimulation to give in real time rather than expecting the patient or the physician to make those adjustments. So another way to look at it is with medications, the symptoms go up and down, but also the brain, what's called beta signal, goes up and down with medication. And what Medtronic does is it can detect using this brain sense feature, can detect the abnormal beta signal. And then now with literally just this year unlocking that capacity. Interestingly, even the older Percept PC and Percept RC that came out, I think in, what was it, 2021 or 2022, something like that. The technology to do adaptive was always present within the hardware that was implanted, and it is now being unlocked by our software, actually. So patients who receive the Medtronic Percept DBS are able to unlock that adaptive feature if relevant and if they're candidates for that by their physicians. And advances also in the Percept PC and RC are that these the RC is rechargeable and it's a much smaller. Actually, I should have adjusted that scale because the RC battery is actually much smaller than the PC battery. And these are all advances across other platforms of DBS, including Abbott and Boston Scientific, that the batteries have gotten smaller, they've gotten smarter. There's, more, targeted therapy in terms of how we angle the stimulation. But the most recent advancement in adaptive DBS is only with the Medtronic device so far. Moving away from an incisional implantable surgery to a non-incisional neurosurgical approach called focused ultrasound. So this did get FDA approved for tremor predominant Parkinson's in 2018. In 2021, it got approved for the treatment of not just tremor, but also unilateral motor symptoms like slowness, stiffness, and dyskinesias. And then this year, they also allowed for bilateral treatment. This is typically a staged approach where first one side gets done, then a number of months later, the second side. The efficacy of focused ultrasound for motor symptoms, not just tremor, but motor symptoms of Parkinson's, is about 52% at 4 months on that one side. But with the and then on the right, you can sort of see that when they used the measure of a 3-point improvement, 70% of patients who got the active treatment showed improvement at 3 months compared to 32% who only received the sham procedure. And at 12 months, a year, those who had been in the active treatment group, a majority of them maintained the treatment response, which was again defined as at least 3-point improvement in the motor scale of that side, because it was a unilateral treatment. In bilateral treatments, there is a similar improvement. Side effects can include speech disturbance, gait disturbance, dyskinesias, and weakness, but they typically improved by the 4 or at least by the 12-month mark. And I like this scale because, again, nothing works 100% of the time in 100% of the people with 100% efficacy. And what this shows us is that those who received the active treatment are in blue, those who received the sham procedure are in red, and each line is an individual patient. So you can see that the majority of people had at least a 50%, had at least a 30% improvement, and on average, there was about a 50% improvement, as you can see. So some people had a really impressive improvement. Actually, I should say a couple people had a really impressive improvement, and a couple of people had really no improvement. And again, the people on the right didn't receive the active treatment. So, a 25% improvement is sort of the 30% improvement is kind of the threshold, and the vast majority of people did receive that, did achieve that. So moving away from motor treatments to preventative treatments, really, I really want to highlight Dr. Tagliati's upcoming talk today on exercise, because that is our current best option, and there's updated data on this all the time. So it's new, so to speak, in terms of new types of exercise. And there's also a lot of evidence for all these other lifestyle things I won't talk about. And you may hear about or read about or get emailed, or your neighbor tells you about, oh, I found this cure, it's going to cure Parkinson's. And a lot of those things are still in the basic science stage. We won't be discussing those today. I just won't have time for that. So just to clarify what we are talking about as far as preventing the progression. Now, we're not talking really about dopamine. We're talking about, well, why do we have dopamine loss? It's because the dopamine neurons are dying off. Why is that happening? It's because of, it's thought to be because of this misfolded alpha-synuclein that clumps together, and these toxic forms that clump create this gunk essentially in the brain, and it disrupts the normal mechanisms of cell function in those dopamine neurons, causing loss of dopamine cells. But unfortunately, it does spread within the brain, and it isn't just dopamine neurons that are affected as the years go by. But the theory is that the alpha-synuclein has a big role to play here. So one of the biggest things that kind of biggest categories that is very promising right now is antibodies against alpha-synuclein. And in preclinical studies, clearing out alpha-synuclein via antibodies was shown to reduce the aggregation, meaning clumping, limit neurodegeneration, meaning reduce cell death, and improve motor function. But unfortunately, that didn't translate quite so well in antibodies in clinical trials. The prasinezumab, as there's still optimism for this drug, because even though, as you can see in, in the top scale here, the blue is those who got placebo initially, and the orange is those who received the drug. In the primary outcome measure, which is the total score of the Unified Parkinson's Disease Rating Scale, there wasn't any improvement compared to placebo, compared to placebo. But when they broke it down to the motor scale, which is usually what's looked at for prevention, there was you can see that those who received placebo progressed faster than those who received prasinezumab early. The other issue is that we don't have a prospective biomarker. I don't, and none of us think that the clinical features of how somebody's looking on their physical exam on any given day is the whole story of what's actually happening within the brain. And we don't have a way of knowing that to understand how we guide treatment. And the other kind of caveat as to why some of these antibodies didn't seem to be effective is that probably, alpha-synuclein is not the whole story. There is other pathology that's happening in the brain, including vascular changes and other natural age-related degenerative changes. And another big part of it is timing of treatment. It does seem likely that the earlier we get started with treatment, the better we will do. But the preclinical studies, they were treating these animal models before the actual sort of, real significant degeneration had a chance to set in. So I'm still optimistic about prasinezumab. It is embarking on a phase 3 trial now. Other antibodies, there is one from Lundbeck, one from Takeda, that are in phase 2-3 and phase 1-2 trials. Nowadays, a lot of these companies are shifting from Parkinson's to a Parkinson's related condition called multiple system atrophy. This has nothing to do with multiple sclerosis, but rather multiple system atrophy, which is a much more rare and much more severe condition that I think they're expecting to see more of a signal of their benefit. And then from there, maybe transition back to Parkinson's trials. Active immunotherapy against alpha-synuclein takes the form of vaccine. So we can use a vaccine to use your body to create antibodies against the abnormal or toxic forms of alpha-synuclein. And the PD-01A affitope vaccine was shown to be safe and tolerable in phase 1. So it got transferred to the AC Immune company, where they optimized it and renamed it. And that's in a phase 2 trial that showed that it was safe and tolerable and that there was evidence of immunogenicity. So the next step will be phase 3 trials. A different company called Vaccinity is in phase 2 already for a vaccine called UB312. Everybody's asking me about stem cells. There have been breakthroughs made in dopamine cell replacement therapy, meaning that instead of just stem cells, which I like to call like a newborn baby, you don't need newborn babies, right? You need, let's say, a taxidermy, right? Because it isn't just any cell that's missing, it's dopamine neurons. So instead of just infusing or implanting stem cells, now what's happening is we've created the dopamine neurons in the lab and implanting those directly into the brain in the putamen. There's 2 ways of doing this. One is from the patient's own cells, and the other is from externally derived stem cells, where with that latter group, you have to have a year's worth of immunosuppressant therapy. So I'm going to highlight Aspen, which is just very, very early in phase 1-2A It's ongoing. They've only published the first 3 patients, but they did show improvement, and that one didn't require immunosuppressive therapy. A couple of other companies are working on this as well. This is going to take time because you really need these long follow-up periods to assess safety, make sure they're projecting correctly their neurons to the correct brain regions, and to verify and monitor for graft survival and the durability of the benefits. The really impressive benefits that have been shown have so far been in phase 1, meaning open label trials. Everybody knew they were getting the treatment. So the next stages are going to require sham treatment to actually be sure that it's the treatment itself and not a placebo effect. Very, very briefly, there are genetically inspired treatments. These genetic mutations, GBA and LRRK2, are mildly common, I guess I would say, in the general Parkinson's population. But even though the majority of people don't have a family history and also don't have these genetic mutations, there's some interest in these genes as potentially being able to create treatments that would help people who don't have these mutations. So people have asked me about Ambroxol. It's actually a mucus removing over-the-counter in Europe, over-the-counter, cold, if you will, medication, kind of, this idea of like clearing out mucus. But the doses that's being used is huge. So it's not available in the United States, and the dose that would require, it's just really very nearly implausible to get it outside of this trial. But there is this phase 3 trial enrolling in the UK, looking at people with and without the GBA mutation, where the concept is that the Ambroxol is going to boost the efficacy of the normal enzyme, and this enzyme is abnormal in the people who have the mutation, and that's going to help properly fold the enzyme, reach the lysosomes, and remove alpha-synuclein. And so, the phase 2 trial showed some signals of efficacy, so we'll have to wait and see what the phase 3 trial shows. There is an ongoing phase 2 trial for a different glucocerebrosidase activator, again, that enzyme. Top-line data is expected next year. Unfortunately, there was a failure in another one of these GBA mutation trials. And then LRRK2 mutation, that the mutation increases kinase activity, so the phase 2 trials are ongoing for a LRRK2 inhibitor to reduce that kinase activity, and also maybe even in future they'll actually use these types of treatments together, a GCase activator and a kinase inhibitor together. And again, this may not be just only for people who have these mutations, may be really useful for people without it as well. So in conclusion, there have been a lot of advances in motor symptom management, new delivery systems for medications, adaptive DBS, focused ultrasound, helping people have better on time and more predictability in their day-to-day. And there is cautious optimism in preventative treatment and dopamine cell replacement therapy. These clinical trial successes that have come to pass, where we have all these new FDA-approved treatments, really depend on the participation of patients such as yourselves or your loved ones with Parkinson's. So if you're interested, ask around, go to clinicaltrials.gov. But I think that it's really a good time to be optimistic about Parkinson's treatments, at the same time doing everything that you guys can do on your end, including taking your meds on time, drinking water, getting your fiber, and doing all the exercise. So thank you all for your attention.
Thank you, Dr. Petrossian. There was one question in, what is an agonist? Someone had asked that references to your reference earlier. There's a couple more coming in now too.
Perfect. Yeah. So an agonist works on a receptor. So as opposed to an antagonist that inhibits a receptor in the brain. So basically, like dopamine agonists activate the dopamine receptor in a similar but different way than levodopa would, or natural dopamine would.
Okay. And also, Luis Torres asked, is Crexont taken in lieu of Sinemet or in addition to?
In lieu of.
Okay. And Michael Bauer asked, you mentioned bilateral FUS. Is that approved for PD?
Yes, it is approved by the FDA. Now, there's a difference I didn't get into, which is FDA approved versus Medicare or insurance going to pay for it. And that's true of medications as well. There's always a delay between, what gets approved and who's paying for what. So, if somebody wants to pay out of pocket, it is FDA approved, ready to go, but insurance may not pay for it.
Okay, thank you so much. Any other questions?
Any last questions?
I am just curious, was the news from last year from MJF about the new biomarker, it made headlines. Is that biomarker different than what you were referencing?
No, when I said prospective biomarker, I'm talking about something that you can follow over time. So a good analogy would be a PSA. A PSA is not perfect, but the prostate-specific antigen that many men are familiar with. So it's not perfect, but you can follow it. So if somebody's PSA goes up, you need to look for what's going on. If they've had treatment for prostate cancer, you want to see that PSA go down, and then if it goes back up again, something's brewing. The biomarkers that we have for Parkinson's, which are great, they've been great, advances in diagnostic availability, which was, of course, not the focus on my talk today. Those are only really a dichotomy. Yes or no? Does this person have Parkinson's or not? And that includes the DAT scan, the SIN1 biopsy, and the one that Michael J. Fox Foundation was publishing about, which is the SAA, which stands for seed amplification assay. It's detecting the abnormal alpha-synuclein in the spinal fluid. So, it really is only a yes or no. It's not a quantitative approach yet, but there is still work being done to hopefully get there, hopefully soon.
Thank you so much. Thanks for all your questions.
Yes. Thank you so much, Melita. I really appreciate it. Big round of applause for Melita Petrossian, Dr. Petrossian. Yes, yes, yes. Thank you so much. Okay, on here. So our next presentation is coming from neurologist and movement disorder specialist, Dr. Adrienne Keener with UCLA, and she'll be discussing nurturing young onset PD, motor versus non-motor symptoms. Can there be gratitude and joy with early onset?
Great. Thank you all for having me today. We're going to chat today, first of all, about what is young or early onset Parkinson's disease. And then we'll talk about some of the unique challenges faced by people who have early onset Parkinson's disease. Though I also want to emphasize that some of the sort of strategies and tips that we'll talk about for thriving with Parkinson's disease during this talk today can apply more broadly to anyone living with Parkinson's disease. So first of all, what are we talking about? So the Movement Disorders Society actually convened a task force around this question of early onset Parkinson's disease. And they have been hard at work trying to first define this term and then launch better research into this rarer form of Parkinson's disease. So over the last 10 to 20 years, actually, there's been a shift in nomenclature in the medical literature from young onset to early onset Parkinson's disease. And there's not a clear reason sort of why this happened, though the consensus is that this may help to avoid age-related stigma, right? So what is the opposite of young? It's old, right? That doesn't sound very nice, but the opposite of early is later onset. And so that kind of makes more sense as to what we're talking about. There was also a discussion, the Movement Disorders Society is a global organization. Discussion really that the term early is actually more globally translatable, right? In different languages, it sort of translates better as early rather than young onset. And we define this as Parkinson's disease with the onset between 21 years old and 50 years old. And 50 is a little bit of an arbitrary number, right? You might be thinking, well, I was diagnosed at age 51. Is that really different? Probably not, but there is sort of, first of all, a need for standardization and definition of this term to help guide future research and help make sure that when we're discussing this entity, we're all on the same page. And there is some biological rationale, one of which is the hormonal influences that we know play a role in Parkinson's disease, and age 50 being the average age of menopause. We also see 50 sort of as a tipping point where the psychosocial impacts of the diagnosis may have different implications. And then just a note here that there is very, very rarely Parkinson's disease with onset under 21 years old, and we use the term juvenile Parkinson's disease to define that. So early onset Parkinson's disease is unfortunately on the rise. It is estimated to represent 10 to 20% of patients with Parkinson's disease. Though if you look at different regions of the globe, this percentage is variable from lower, close to 5 to 7% in the United States, and then higher in certain regions, including Japan and India, that are reporting higher rates of early onset Parkinson's disease. We know that there is a role of genetics in the pathogenesis of Parkinson's disease, and the younger your age of onset, the more likely genetics may be playing a role. There is a family history of Parkinson's disease in about 20% of people with early onset, compared to less than 7% of people with later onset Parkinson's disease. In the just published this year data from the 2021 Global Burden of Disease study, we saw that early onset Parkinson's disease does seem to be on the rise, both rising incidence and prevalence rates, increases in disability adjusted life years, as well as significant geographic and socioeconomic disparities. And so I think this really highlights the need to look more specifically at the impact of early onset Parkinson's disease and how it might be disproportionately affecting people around the world. We also know that there is often a delay to diagnosis in people with early onset Parkinson's disease, and there are several potential explanations for this. I think one of them that we have to acknowledge as neurologists and movement disorder specialists is that many clinicians may not consider Parkinson's disease as a cause of symptoms in younger people. This image here on the right is one of my favorite, from a paper by Michelle Armstrong and Mike Oken about changing the image of Parkinson's disease. So in early onset Parkinson's disease, we might see different presenting symptoms. We might see, for example, a foot dystonia as the presenting symptoms, and not, the slow shuffled gait of an older person. I think also early symptoms can be misattributed in younger patients. So symptoms of stiffness, muscle cramping, shoulder pain, even depressed mood can be attributed to other conditions. I think many of us have seen patients with early onset Parkinson's disease who have had a long diagnostic saga, seeing an orthopedic surgeon for a shoulder problem, hopefully not undergoing an unnecessary surgery, but really taking a long time to make their way to a neurologist who recognizes the diagnosis. And then finally, as I mentioned, the different motor symptoms that patients with earlier onset disease can present with can also be a reason for that delay to diagnosis. So let's talk about the common motor symptoms in early onset Parkinson's disease. So dystonia is probably one of the more common and distinguishing motor features of early onset Parkinson's disease. At diagnosis, up to 20% of early onset PD patients have dystonia, often involving the foot, as illustrated in that prior image. And this can include what we call exercise-induced dystonia, so a dystonia that only emerges with exercise. We also see that within the first several years of treatment, many early onset Parkinson's patients develop dystonia as a motor symptom. So even if it's not present initially, it is a frequent symptom that they develop early in the course of their disease. On the other hand, early onset Parkinson's disease patients are less likely to have balance issues. Many reports suggest that they're less likely to present with the classic rest tremor that is probably one of the most recognizable symptoms of Parkinson's. And this is probably part of what belies the delay to diagnosis. We also see a slower overall progression of motor symptoms in early onset Parkinson's disease. But of course, these patients are going to be living with the disease for a much longer duration. And so this has particular implications for treatment. So we know that early onset Parkinson's disease patients are more likely to develop dyskinesias once treated with levodopa therapy. One study demonstrated that after 5 years, up to 80% of patients develop dyskinesias, and this is compared to older onset patients where the rate after 5 years is about 25%. And that rate goes down the older you are. We also talked about that treatment-related dystonia, that if not a presenting symptom, can emerge as a complication of therapy. Dystonia, on the other hand, may not respond well to levodopa, and so exploring other treatment options for these patients, including anticholinergic medications, botulinum toxin injections, and of course, physical therapy. Many early onset Parkinson's disease patients, for this reason, may try to delay the use of levodopa, but this has its own sort of downstream implications. There was, I think, a trend for several years for using dopamine agonists as a levodopa-sparing approach in earlier onset Parkinson's patients. But one thing we also know about early onset PD is that young age is one of the biggest risk factors for development of impulse control disorders with dopamine agonist use. This image here is from a study looking specifically at impulse control disorder development among early onset Parkinson's patients on dopamine agonists. You can see there are some gender differences here, but the rates of ICDs among our earlier patients really warrant close monitoring. And many, I think, specialists have reconsidered using levodopa earlier in this patient population because of these potential side effects of the dopamine agonists. Now, Dr. Petrossian was just highlighting newer dopamine agonists that may have less of these side effects that's in the pipeline, and so we will be excited for that. Lastly, I also want to mention deep brain stimulation. There was a study called the Early Stim study looking at earlier DBS for patients with motor fluctuations, and I just want to point out that in that study, actually, the mean age of the patients was 52, with a mean disease duration of 7 years. So that study really was largely looking at early onset Parkinson's disease patients and the benefits of deep brain stimulation to address motor fluctuations. There are some additional considerations and I think a unique intersection for women who are also diagnosed with early onset Parkinson's disease. So those of you who have heard me speak on the topic of women's issues before have probably seen these figures from a paper I published with one of my colleagues, Dr. Subramanian, a few years ago now, talking about the different sort of hormonal phases in a woman's life, many of which are in the early age group, right? So many women report worsening symptoms with their menstrual cycle. There's very limited data on pregnancy for women with early onset Parkinson's disease. And then again, a worsening of symptoms as women enter perimenopause. There is some hope, however, because although pregnancy and family planning is sort of underappreciated and I think under-researched area in Parkinson's disease, there have been some recent advances and efforts made in this area. So we know that many women experience worsening symptoms during pregnancy, but we also have pretty good data that neither Parkinson's disease itself nor levodopa therapy increase the rates of infertility, spontaneous abortion or miscarriage, or fetal or maternal complications. So the same MDS YOPD task force that published the updated definition and criteria also published just this year, actually, guidance for management of Parkinson's disease in pregnancy, from which this figure is taken. I also want to highlight here the PREG-SPARK study. This is a registry of pregnant women with early onset Parkinson's disease that is actually spearheaded by an obstetrician who herself is a woman with early onset Parkinson's disease. And so gathering more data, experience from women around the world through this registry will shed more light on this area of care for early onset Parkinson's disease in women. Talking now a bit about the non-motor symptom burden in early onset Parkinson's disease. So we often refer to the Parkinson's iceberg as the motor symptoms are the things above the surface, the things that we see externally. Well, under the surface is the greater burden of the non-motor symptoms in Parkinson's disease. And as with some differences in motor symptom presentation, we also see some differences in non-motor symptom presentation. This figure here is from Ray Chowdhury's group. He's sort of the king of non-motor symptoms in Parkinson's disease. And they propose here sort of a non-motor profile. You can see depression, anxiety, pain, sexual dysfunction, impulse control disorders, and stigma and psychosocial issues really dominating here. Depression in particular is at least twice as common in Parkinson's disease That's earlier onset versus later onset. And it's often a symptom that I think is sort of under-recognized and undertreated. So we know that non-motor symptoms have a significant impact on quality of life for Parkinson's disease in general, and that also is true in young onset Parkinson's disease. So we see, as I said, higher depression rates, greater stigmatization in this population. And interestingly, even with the same sort of motor disease severity, patients with early onset Parkinson's disease report a worse quality of life compared to their later onset counterparts. This paper by Schrag and colleagues emphasize that the social and psychosocial factors, including role expectations, may contribute to the greater impairment of quality of life in young patients. And so we're going to spend a little bit more time talking about those issues. So I want to introduce here another woman living with early onset Parkinson's disease, who's also a physician herself and has done great work advocating and publishing in this space, Sonia Mather. She's the author of this article with another patient called What People with PD Want. And they sort of highlight here the factors that they see impacting their quality of life with early onset Parkinson's disease. More recently, there was a survey study of nearly 200 people with early onset Parkinson's disease, asking them what are the top 5 things of your unmet needs. And number 1 was a need for a community more like me. Number 2 was more information about Parkinson's disease itself. Number 3 was more information about the future, how their Parkinson's disease will progress. Number 4 was the mental health issues. And number 5 was employment. So let's talk a little bit more about those. All right, so this figure here is, I think, and I put a flower here for our garden that we're nurturing. I think this really is a beautiful figure that is hard to read, but try not to read it all. But this is what has been termed a mind map. And this was actually created by a patient with early onset Parkinson's disease in the Netherlands, where they have established an early onset Parkinson's disease clinic that is sort of tailored to the needs of this patient population. Pretty amazing. But you can see here, actually, the physical state, the motor symptoms are like the smallest petal of the flower in this mind map. But many other things, relationships with their partner, their children, their social relationships, concerns about decline in social participation and loneliness, uncertainty about finances. This feeds into the workspace. How are they going to navigate changes in their profession and what they're able to do at work? And so I think, this is sort of a helpful tool to think holistically about the way that a diagnosis of Parkinson's disease may impact anyone, but with particular attention to some of the unique considerations for earlier onset patients who may be at a different phase of life where they're still working. They may be caring for an older parent. They have young children. A lot of things that they're trying to balance at a different phase of life than our later onset patients. So I think part of what we see in this population is a lot of what's been termed demoralization. So a lot of difficulty sort of adjusting to the diagnosis. Later today, you'll hear more about this from our neuropsychologist, who's going to talk about sort of accepting the diagnosis and ways perhaps that psychotherapy can help with this. But we see, I think, what is sort of a phase of sort of grief that happens when people receive a diagnosis, especially of early onset Parkinson's disease. They have all these hopes and dreams and plans and images of what their future is going to look like. They receive this diagnosis and they almost have to go through a phase of grieving what they thought their life was going to look like so they can accept and move forward with this new information, living with Parkinson's disease. So again, you'll recognize Dr. Mather's name here. She's quoted and as a co-author in this paper as well. And she says, ultimately she recognized her power to choose optimism over despair, began to understand that although the diagnosis is not simply within my control, how I face this challenge is ultimately mine to determine, moving from a position of hopelessness to one of true power. And so I think as physicians, as care partners for patients, particularly with early onset Parkinson's disease, this sort of moving from demoralization to empowerment to hope, I think is really key in thriving and living well with early onset PD. Now, I mentioned some of the unique maybe relationship issues that can come up with people of early onset Parkinson's disease, and also the recognition that sexual dysfunction is more reported as a significant non-motor symptom that drives quality of life in this population. So there was a survey of in 2010 of about 60 people with early onset Parkinson's disease that I think sort of highlighted the impact that the disease can have on their relationships. In this case, it was specifically their spousal relationships. So 57% of patients rated their relationship satisfaction as poor or worse. And among 32 couples, relationship satisfaction was highly correlated, meaning if the patient with Parkinson's disease was dissatisfied, so was their partner. Depression also correlated with both the relationship dissatisfaction of the person with Parkinson's as well as their partner. So it impacts not only the patient that you're treating in front of you, but also their partner who's helping to care for them. And 37% of participants in the study reported sexual dissatisfaction, and that correlated also with relationship dissatisfaction. And I think sexual dysfunction is actually one of those non-motor symptoms in Parkinson's disease that many of us do a bad job of addressing or even asking about. And it's one of those topics that can be difficult for people to bring up spontaneously as well. And so I think for us as people caring for patients with early onset Parkinson's disease, we have to ask this question, and not just of men about erectile dysfunction, but also this question of women about, pain with intercourse, dryness, other loss of libido, other symptoms in the sexual dysfunction domain, so that we can try to help address these. I think the other thing that can happen, particularly in spousal relationships, is that shift from, sort of partner in the marriage to one person taking on a caregiving role for the person with Parkinson's disease. And that shift in dynamic, I think, also can be difficult to navigate and can have an impact on the relationship satisfaction. This quote here is from a qualitative study where they interviewed people with Parkinson's about the impact on their relationships. And I think it really will help us transition now from talking about family relationships to employment. So this patient said, although I realized that getting this disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. And so employment is another really big area that I think needs to be uniquely addressed for patients with early onset Parkinson's disease. So I think there's a lot of stress about being able to continue working, when and how to disclose their diagnosis to their employer. Studies have looked at this in various different ways, but one study showed that after 10 years, patients with early onset PD, 90% have lost employment. Another study showed that the median time to loss of employment was 7 years. And among those still working, the vast majority have had to make adjustments at work. And then a more recent study used the World Health Organization Disability Assessment Schedule 2, which looks at these 6 different domains and tried to compare disability in early versus late onset Parkinson's disease. And what they found was that the overall levels of disability were similar when adjusted for the duration of disease and disease severity. However, those with early onset Parkinson's disease had more work-related disability. So this domain 5, domestic responsibilities, leisure, work, and school. And the consequences of unemployment for this patient population are not just the financial loss, the cost, but also social isolation, feeling a lack of purpose, their impact on their self-esteem and self-image, and also the lack of a daily structure that, having a job can provide for somebody. So I think for many people, in their 40s, they're sort of in their prime of their careers, and a lot of their identity is wrapped up in their work. And so when they receive a diagnosis of early onset Parkinson's disease, that can really impact their social structure, their sense of self-worth. And so I think working with patients to provide support around the workplace and employment is really key. So going back to the mind map, we can sort of see how this might translate into different domains of well-being for our patients with early onset Parkinson's disease. And so when we talk about nurturing wellness and nurturing our garden in early onset Parkinson's disease, we really are talking about supporting the patients and interacting with society and living with the disease for a longer period of time compared to the later onset PD colleagues. And so this, I think, really highlights the importance of individualized and patient-centered care that's tailored to that person's phase of life Are they wanting to have children? Are they wanting to remain in the workplace? We have to meet people where they are and really expand our treatment team to include perhaps more than the traditional sort of medical team, but also maybe a family therapist to provide caregiver support, vocational retraining. Maybe you need an employment or disability attorney, a financial planner. And so I think really sort of expanding that to meet our patients where they are. And in early onset Parkinson's disease, I think this includes trying to address their role in society, in their family unit, in the workplace. I also want to highlight here, I think, the other thing that anyone with Parkinson's can do, but also important in early onset Parkinson's disease, which is really attending to the rest of your health. So with early onset Parkinson's disease in particular, we are going to help you live for 30, 40 years with Parkinson's disease. But in the meantime, you also need to be keeping an eye out for the other things that happen as you get older in life. So things like blood pressure, diabetes assessments, your vision, your gut health, even your dental health can play a role. As women enter menopause and that postmenopausal area, the bone health becomes increasingly important. And so this again from Ray Chowdhury's group, what he termed the Parkinson's Vitals Dashboard. So things beyond just the motor and non-motor symptoms that we need to tend to as we cultivate our garden to prepare really for a long life with Parkinson's disease, especially if you've been diagnosed earlier in your life. And so this, again, goes back to expanding that multidisciplinary care team beyond sort of the traditional players in the care team for people with Parkinson's disease, putting the patient at the center and really using all of these other sort of support structures to help them thrive with Parkinson's disease. So there is some hope. There was a recent study that actually demonstrated that in over time, patients with early onset Parkinson's disease actually had better quality of life and less caregiver strain than those with later onset Parkinson's disease. And this contrasts to some earlier cross-sectional studies looking at quality of life in this population. And this came out of the Parkinson's Foundation Quality Improvement Initiative. And what the authors state in this study is that they hypothesized that young onset PD patients, after being initially more struck by their diagnosis, have better capabilities to adapt to their disease, a stronger social network, resulting in better quality of life over time. But I think what's key here is that this came out of the Parkinson's Foundation Quality Improvement Initiative, where Parkinson's Foundation Centers of Excellence have additional resources to help bring together that multidisciplinary team to support patients. And so, several years ago, my colleagues and I published this prescription for wellness in early PD. And I think this is really sort of what is the secret sauce, right? These people who do see that, recovery and even improvement in their quality of life after a diagnosis of early onset PD, what is the secret to their improvement? And we think there is a role for sort of self-efficacy, resilience, social support, and sort of learning those coping skills of psychological flexibility that really helped people to thrive with their diagnosis. Here again, another quote from Dr. Mathur, who also authored a book with her 3 children about how to talk to your kids about your diagnosis. And what she says, again, is in your battle with Parkinson's disease, knowledge is power and attitude is everything. You must be an active participant in your disease management, actively seeking solutions to problems that arise, and take on a proactive approach to accessing appropriate resources. And lastly, from one of maybe the most famous patients living with early onset Parkinson's disease, Michael J. Fox, at his documentary Still, which I hope many of you have seen, won an award at the National Board of Review. And at the gala where he accepted this reward, he said, "Parkinson's has been a gift. It's been a gift because it's given me an audience to talk about what's possible." So I think the key to, sort of thriving with early onset Parkinson's disease, and really with later onset Parkinson's disease as well, is to look for opportunities for growth. I'm going to highlight here sort of other ways to get involved. So we have Several different organizations, really spearheaded by people living with young onset Parkinson's disease. Opportunity to attend the World Parkinson Congress, which is just next door in Arizona in 2026, to meet other people living with Parkinson's disease. And so I know that we're a little bit over time, so I will wrap up here quickly. Just to conclude, people with early onset Parkinson's disease are often juggling professional responsibilities and their identities as a partner, a parent, a caregiver to their aging parents simultaneously. There are delays to diagnosis, I think challenges adjusting to the diagnosis, high rates of stigma in this population. From the motor perspective, dystonia is often a presenting symptom that is mischaracterized. They have a higher likelihood of dyskinesias than later onset patients. And in the non-motor domain, we need to address symptoms of depression, impulse control disorders, pain, and sexual dysfunction. For women in particular, the impact of hormonal cycles and guidance around family planning is really necessary, as well as education and support for family members and other healthcare professionals caring for people with early onset Parkinson's disease. So while the disease progresses slower, they have a longer duration of disease, but this basically translates into a long window for opportunities for growth along your journey with early onset Parkinson's disease.
Thank you so much, Adrienne. We have one question in here, which we'll take it very quickly. What is the difference from, it's from ECOW, what is the difference between dystonia and dyskinesia?
Oh, that's a great question. So dystonia refers to sort of involuntary muscle contractions or cramping that can cause involuntary postures. Dyskinesia really is a bigger sort of umbrella term that refers to extra involuntary movements that are often a side effect of levodopa therapy. Sometimes dyskinesias can take the form of dystonia, but sometimes dystonia can be a symptom in itself apart from levodopa therapy. Dyskinesias more often have sort of that wiggling, writhing, sort of fidgety, unsettled appearance, whereas dystonia is more of like a cramping and posturing, often of a foot or a hand in patients with Parkinson's disease. Great question.
Thank you. I invite everyone to read the chat also.
Yes.
There's some comments from Luis Torres. I think it's very valuable. Thank you.
Yeah, and I think your experience, Luis, is not alone. I think you're not alone in feeling alone at the time of your diagnosis. So thank you for sharing.
Yeah. One of the things I'll just say briefly that, you see one person with Parkinson's and you see one person with Parkinson's, you see some commonalities, but you never stop seeing something that looks slightly different. But the one thing people with Parkinson's all have in common is that moment to that journey to, and that moment of diagnosis. That's the one thing they really all have in common. And that occurs in many different ways. It can be done compassionately, dismissively, but we're in the fight together. So I think that's all our questions for now. So Adrienne, thanks so much.
Thank you all.
Constant. Thank you. So we have a video we're going to play you here. Judy, did you want to say something about Robert's? No? Okay. So it's kind of one of the members of our community wants to talk a little bit about his journey and what PCLA is to him. So Josh, I'll turn it over to you.
Hi, my name is Robert Campuzano. I am 58. I was diagnosed in 2023, in April of 2023. It's been challenging at the same time, of course, because when you find out you have Parkinson's, you don't know where to start. PCLA was an education. It was basically, it taught me where to start from and how people have been going through it in their system and how they got started. It opened my eyes and to realize that, people can still have a normal life, or at least try to get as normal as possible, especially with Parkinson's, depending on how aggressive it's already taken over your life. So, but the people in PCLA, they're funny, they're educational. If you have questions, you can feel comfortable of asking. That's kind of the nicest part, Nobody's the same. Everybody was actually different in their Parkinson's. And there is a different age group, and I was 58, so the people that I saw in there were much older. So it was just like wondering, is that how I'm going to turn out? No, it doesn't. At the end, it doesn't mean they're going to be the same way. It just means that you could still have a life. And there's people are laughter and smiling and talking about good stuff and talking about the bad stuff. But the combination just makes you feel good about the direction you're going, at least. And it's good to have people that that pat you. It felt like a pat on the back that you're okay. We're here. We're a family. It's a family experience. The same thing. So if you don't have that, I mean, it's the best thing for you to do.
So I want to thank Robert for having the courage to come on here and talk about his journey. And that's what I think we are really so lucky. I'm looking at all the faces here. We're so lucky to have such a wonderful community that has such courage and generosity and this willingness to share. We're so fortunate to have you all. So we're going to move on to our next speaker. Dr. Nicholas Szumski is neurologist with Cedars-Sinai, and he's going to be discussing newly diagnosed, when to start medications, weighing the pros and cons and long-term considerations. A long-term friend of PCLA. Welcome, Nick Szumski.
Hello, everybody. So yeah, Dr. Szumski, I'm over at Cedars-Sinai, and a little, almost literally breathless, because I was just running around the hospital seeing patients. And so there's a small chance my pager will go off during this talk, but I'm crossing my fingers that we've paid our dues already. My topic is, I think, technically about starting a medication for the first, and I want to kind of broaden it a little bit, or at least promise to the people here that it will be expandable to people who have been on medication for a while, even a long while, because I think some of the factors that play into when and how to start medications keep repeating themselves as time goes on. And it just changes, the question changes, do I need to change medicine? Do I need to add medicine? Do I need to do something differently? One of the things I want to address first, because it comes up so frequently, is there's a very pervasive myth of what you might call the ticking clock of levodopa. Many people have heard from peers, from the internet, from written materials, even from their doctors, this strong sense that once you start medication, you only get a certain amount of time, and then what? Then, does it stop working or something? But people have the impression that something bad happens. And that really came to a head some years ago when I talked to a patient about starting medication, and she had made it through the conversation about the new diagnosis pretty well and so forth. But when I mentioned levodopa, she started tearing up and crying. And that was a little unexpected, because I thought we'd already talked about some of the difficult parts. And basically she let me know she was scared, because she was under the impression that if we started that medicine at today's visit, that her clock would start ticking and she'd only have X amount of years, and 7 years seems to be the most common thing that people have heard, give or take. But she was very afraid that if we started the medicine, this loss of effectiveness that might happen in the future would still be ahead of her. And so we had a long talk about that, and tried to reassure her, but it's come up in a lot of different forms. So I want to make it really clear that medication does not stop working. After 7 years, 10 years, we have patients who have been on levodopa or other medicines for 25 and 30 years. And trust me, if we stopped their medication, they would miss it. It is still working. What does happen over time is it gets trickier. It gets more complicated. We often have to increase the dose. We may have to adjust the schedule. We may have to navigate side effects, other issues. And the development of motor fluctuations, which I'll touch on a little bit more, is often thought to occur somewhere around 5, give or take a few years years into Parkinson's. And so I think the origin of this myth is sort of, it's not really 7 years and your medicines stop working. I think it's more like, by 5 to 7 years, there's a pretty good chance things will have gotten a little more complicated, possibly quite a bit more complicated, but your medicine will still work. It'll just need more man. With that said, because that's a major factor in starting medications is, if you're afraid that starting them will somehow use up medicine that you need later in life, that's one of the first things I want to dispel, so people don't have that feeling that they have to decide which 7 years or which period of time they would take their medication, because that's a very difficult way to look at it, very difficult decision to make. So let's talk about the decision in a broader sense. For a long time, and to me, this era was really a few decades ago, the pervasive thought in treating Parkinson's was generally, let's wait until, as long as we can. And that's a kind of a dangerous phrase, because as long as we can, some people could literally get by with no medicine for a long time, but it would change their life tremendously to do so. And so I think that those words did get some people into bad situations because they heard or understood they were supposed to wait until they just couldn't wait any longer. I think that the era came to an end or transformed. It used to be called the era of levodopaphobia, sort of the fear of levodopa, the fear of starting it. And increasingly, and definitely how I would practice now, is that we should start medications, I feel, when Parkinson's is getting in your way. That's, again, a very personal and interpretable threshold. How it gets in your way depends on the time of life when it might occur. Are you working? Do you have a family? Are you traveling? What are your interests? What are your goals? What are your hobbies? How it might get in the way could depend very much on what is important to you. But I also think that's really important to consider. For example, if someone felt like they had been diagnosed with Parkinson's, it was relatively mild, it didn't affect their ability to walk, maybe it doesn't affect their ability to work. Maybe it does affect their ability to play a musical instrument, and that's something really important to them. That would be an example to me of Parkinson's getting in your way, but not waiting for some artificial threshold. You don't have to wait until you can't work. You don't have to wait until you can't exercise. I don't want you to wait until those things are true. But when it starts to impede on things that are important to you, that's when I think is when it's really time to start taking medication. One of the things that can happen, and I've seen happen, is people can sort of insulate themselves from aspects of their world, aspects of their life. And I think of it as the world shrinking. In other words, if I try to do all these things, Parkinson's gets in the way. But if I give up on travel and I retire, even though I wasn't ready to, and I stop playing tennis and so forth, you can get a smaller world where you could say, oh, it doesn't bother me anymore, but it made your world shrink to get there. So the reason it doesn't bother you is because you've given up things that it was affecting. And I'm always on the lookout for those kinds of comments, because the thing that's affected by Parkinson's may have already gone by the wayside, and it's almost out of sight, out of mind in some cases. And so if it's caused somebody's world to shrink, I will talk about, like, we want medication to help you push back and try to resume some of those activities or replace those activities with something that's valuable to you, and not just let the world continue to shrink, waiting for the perfect time to take medications. Another important reason to think about taking medication early, when it's starting to slow things down and starting to affect you, is the ripple effect that it can have on exercise. Exercise as probably has been emphasized many times already, and it can't be emphasized too many times, exercise is crucial in pushing back against Parkinson's. And if motor symptoms keep you from exercising, then you might find yourself on a downward slope that's not Parkinson's or is faster than Parkinson's. It's because you're getting deconditioned. It's because you're no longer walking. You're no longer playing tennis. You're no longer exercising the way you used to. And it can give the impression that Parkinson's is just sliding right in front of you. But in fact, a lot of that can be recoverable. If we can tune up your medications or get you on medications to enable you to resume or start regularly exercising, you may see that your baseline functional status actually improves, which kind of goes against the conventional wisdom and the underlying truth. We know Parkinson's is a progressive disease, and we have not figured out a way to slow it down or stop it. But that doesn't mean the person in front of me, when I'm taking care of somebody with Parkinson's, that they have to progress in front of me. And I've seen patients who we've gotten on the right set of medicines who have remained stable for quite a long time. Could be 6 months, could be a few years. I think the longest I've ever seen somebody stay really in good shape on the same set of medications was about 5 years. And in some cases, this is really important, getting onto medication got them into or enabled them to begin and really benefit from an exercise regimen and physical therapy. And I've seen people get stronger and walk better and be more active as a result of this new push towards exercise and making the medicine a tool in making sure you're able to do that. There are lots of examples local to us. Somebody who I knew years ago, I'm not sure he could be on this call today, but I know there was somebody who is kind of well known here in LA for becoming a marathoner after the diagnosis of Parkinson's. And that's certainly not for everyone. And that's not the goal that everyone would want to have. But it is interesting how the diagnosis and the right medications can set you up with the right game plan to actually get yourself in shape and healthier and better than you would have been had you not had Parkinson's and just continued to not exercise. I will throw in here a concept that I share with patients, which is a little hard to swallow, I think, if the diagnosis is new to you or if you're struggling. But some on this call will probably agree. I believe it's possible to think of yourself as being a healthy person with Parkinson's. And that comes with some optimism and reasons to think that you can do more things if you just get the medicines right. It also comes with some responsibilities, and I saw Dr. Petrossian listed some of those in one of her slides. In other words, you can't stop getting colonoscopies. You can't stop paying attention to, your blood pressure, your diabetes, and other things like that. You need your vessel to be in the best shape it can be, and so you want to be a healthy person with Parkinson's, not a person with Parkinson's who lets other things go. So what kind of factors would play into timing and selection of a medication? Well, as I've emphasized, I think first and foremost is the symptomatic need. There's something going on that if we could just make it better, barriers would move out of the way or be lowered, and presumably we can improve quality of life and get you doing things you need to do and want to do. There are many ways by which medications could be started. There are literally a number of medications out there. And so this talk is not going to be about actually trying to individualize that for you, but factors include, of course, costs. What your insurance company has to say about costs and out-of-pocket, can change a lot what's available to you. Goals, are you trying to achieve a lot right up front? Are you trying to achieve a little? So somebody with milder symptoms might do something that's less potent to begin with. And then another factor that I think I actually underscore or highlight this with patients. My biggest hesitation in many cases to starting levodopa on a patient is not the levodopa itself. I'm not worried that I'm starting it too soon. I'm not worried it's going to stop working if we do this. The biggest step or the biggest line that's crossed when you start levodopa is essentially the need to take a medicine multiple times a day. Starting up a 3 times a day medication is a lifestyle change. It's a lifestyle commitment. And there are times where the benefits are apparent enough that 3 times, 4 times, 5 times, whatever, might you just do it because that's what you need. On the other hand, there are times where people's symptoms are modest enough that trying to aim for 3 times a day would actually interfere with life, with work, with travel, with other responsibilities. And so deciding to cross that line may may keep that factor in mind. In fact, I can think of just a patient just this week where we started medication, and it was kind of borderline whether we should go the route of a once-a-day medication like Azilect, low potency, low risk, but once a day, which makes it very convenient, or something like levodopa, which is more likely to pack a punch and produce benefits, but comes with the 3 times a day responsibility. And the patient, her actual choice at first was to take no medication, but we had a talk similar to this. And so we agreed together that once a day was a good place to start. And if it felt like it was helping, but not adequate, or if it wasn't helping, we would just consider the other options at the next visit. So her expression of not wanting to start medications is not uncommon. Many people have reasons for why they're unnerved about medication. They may have levodopaphobia, if you will, the fear that if they start it, they'll run out. But they may just worry about side effects or things they've read online about what could go wrong. So it's important to bring up those topics in this discussion. If you're worried about something, just please say so. If there's something you're afraid of, please tell us. If there's something you heard that makes you think, I heard that somebody I knew was on that medicine and something terrible happened and they thought maybe the medicine did it and I don't want to be on the medicine, please share that so we can address it and really discuss where it comes from and how we can put your mind at ease, either by selecting something else or really talking through whether, is that a reasonable risk? Is that something you truly need to be worried about? Or is that maybe going a little bit far to worry about someone else's side effect or someone else's health condition that might have not even been medication? One other thing that does come up, and this is for patients, as well as I will also say this is something for caregivers to hear about, spouses and so forth. One of the sources of resistance to medication is Parkinson's itself. There's sort of a peculiarity about Parkinson's that can cast the low dopamine state, can sort of cast a negative light on a lot of things. It's very easy to think of that could go wrong and this could go wrong. And sometimes it's not very clear what those fears are, but they're felt. And so sometimes we need to address the fact that those very fears that are keeping people from wanting to be on a medication may stem from the state of Parkinson's that they're in. It may not be a cognitive conclusion that they've read about or they've heard about and they've decided it's not for me. It may come from Parkinson's itself kind of casting this pall on things that can make the decision of medication seem scarier or bigger than it otherwise would have to be. When you start a medication, presumably you've talked to your doctor about some symptoms that brought you in to see a specialist that led to the diagnosis of Parkinson's. And so how will you know your medications are working? People ask me this a lot. It stands to reason, and it's intuitive. Well, if you had tremor or stiffness, then maybe you'll know the medicine's working because you'll have less tremor or less stiffness. And that often is the case. But I answer that question with patients often a slightly different way, which is, well, you'll tell me. And the reason I say that is because I've had countless patients who have come in because, let's say I'm having handwriting troubles, my hand shakes when I try to do certain things, my leg is dragging. We start them on medication, and I ask, is it working? How do you feel? Many of them start by saying, yes, it is. And they'll kind of gesture to themselves, like, oh, I feel better. And I'll ask, has it helped the tremor? And the answer might be, oh, yeah. Oh, I guess it has. Hasn't been a problem. Has it helped your handwriting? Now that you mention it, it has. Are you still dragging your leg? Oh, yeah, not as much or almost never. And what's kind of interesting about that conversation is you'd think, well, those are the symptoms that brought you in. So aren't those the ones you're going to notice first? But in reality, what a lot of people experience when they start medications is it can provide a feeling of wellness, a sort of an intrinsic feeling that I can't tell you what it is because I've never felt it. But I can tell you patients have referred to this over and over again, that they just feel more like themselves. Sometimes they'll say they feel more comfortable in their body. They feel more like their old selves. They feel more like they don't have Parkinson's. And it's a feeling that seems to be the absence of like something was wrong, something felt off. And sometimes that feeling goes away. And also the motor symptoms improve. But you might be surprised that that feeling going away is sometimes number one on their list when they're happy the medicines are working. So I want to expand it now to think about when should you change medications? And I think the theme is similar, and I don't mean change by necessarily just jumping from one to another, but when should you make a change? That change could mean taking a higher dose, more doses, closer together, adding a new medicine. There's a lot of different variables now. It's impossible to cover them all, but kind of like what I said with patients starting a medicine, I would encourage you to be a squeaky wheel with your specialist. Even if things are going well, tell us what isn't going well. Tell us where you still wish we could do something better. Because you may be surprised. Sometimes a little tweak, a little adjustment, and we can help that too. We don't have to just focus on the primary symptoms that brought you in, and you don't have to settle and say, well, I don't want to be greedy. I guess I'm feeling pretty much, pretty well, not great, but pretty well. I guess that's pretty good, right? I encourage people to aim high. And I tell them, we can't always get you there and we can't always keep you there. But if we keep aiming to get you feeling better, it keeps our eye on the ball. And so I would encourage you to be, as I said, a squeaky wheel. Mention where things don't go as well. Mention how they don't go as well. What is it that's not going well, whether that's a symptom or an activity or a time of day where things don't go as well. Factors in changing medicines could include if you're having side effects or you're concerned about side effects, if costs have changed, if you're on a medicine that was covered by your insurance last year but not this year, speak up. There's a very good chance that we can make a change to something that's much more cost effective without you losing ground, maybe even gain some ground. Speak up if your medicines don't work well for you consistently throughout the day, if they wear off, if sometimes your medicines don't seem to work. Speak up about that because there are adjustments we can make. If you notice symptoms that are outside of Parkinson's, and I can and have done a whole talk on the non-motor symptoms of Parkinson's. It's a list that's too long, but sometimes we get the tremor and the stiffness and slowness well in hand. And the problems are constipation, sleep disruption, depression, and so on. And we don't want to rest on our laurels and say, well, at least you're not having tremor. We put that battle aside if we have that well in hand and say, okay, but we need these other things to be better too. We can work on your constipation. We can improve your sleep. And those things are important for quality of life and for being an effective person with Parkinson's. So my main thought for everyone is strive to feel better, to get better. Don't be afraid to ask your doctors who are managing your medications, how can we address these things that are not quite the way I would like, that could be possibly improved. We can't fix everything, but we have a lot of ability to make adjustments that can work on your behalf. But we need to hear from you what you're experiencing so we know where those weak spots are, what we're trying to achieve. And then a final plug, I mentioned it before, and I also said you can't mention it too often, so I will mention it again. The best medication for Parkinson's, I think, is exercise. So regardless of your decision of when you're going to start taking pills or using other pharmaceutical treatments, please focus on including exercise in your program. It's really powerful. It does a lot for well-being, not to mention for your heart, lungs, and otherwise. It's good for your body for a lot of reasons, but it's good for Parkinson's. So I hope somewhere in there you found some words of wisdom that you might find useful for a future conversation between you and your prescribing neurologist. I will put in a plug. I think somebody mentioned this not too long ago. I think it is very valuable for patients with a diagnosis of Parkinson's to have a movement disorder specialist in their corner, even if that's geographically a challenge in this era of video visits, or we can sometimes share a patient. You might have somebody locally who's close by who may come and see a movement disorder specialist a part of the time. But definitely you want one of us in your corner because we have a lot of tricks up our sleeve. With that, if there's time, I'll leave it open to questions.
I'm going to let Judy field a couple of questions that we have, but I just wanted to make a quick comment. Nick, I love hearing you talk because there's always multiple things I take with me and end up stealing and using in my practice. But one thing that strikes me is that I think that there's a stigma attached to people who complain. And I think kind of what you were saying is, as a Parkinson's patient or a care partner, to free yourself up to talk about everything, to complain a little bit, and to take note of the even smaller things that are bothering you and not try to put a good face on stuff.
Yeah, it doesn't help that years ago, the field of medicine decided that the main reason person came to see their doctor was called the chief complaint. And patients over the years have frequently said, well, I'm not complaining. I'm just telling you what my symptoms are. And I have to explain. I understand, but it's in a medical sense, complaint means something different than,
Right.
if you don't like this flavor of ice cream. But that's why, yeah, be a squeaky wheel, speak up for yourself. And I like to remind people, not everything you'll bring to our attention is going to be Parkinson's, but a lot of things that you may not think are Parkinson's could be related. So as they say, throw it at the wall and see what sticks. Bring it up, and we may grab a hold of a symptom that you did not think was in our area, but we may claim it and help you out with it anyway.
Thank you so much, Nick. I wanted to say we have the comments, no questions, but from Louis, he wrote, totally agree. I exercise 6 to 7 days a week for 30 minutes and firmly believe this has helped me tremendously. And then Randy wrote, I think it was referring to something you had said that happened to me. I went from desk potato to ultra marathoner in mountain trail running and racing. I am certain I gained 5 superb years of life. And it looks like there's someone else wrote one thing. I am passionate wait a minute, I've covered it.
Patients must be, yeah, Randy's amazing.
Yes, how passionate patients must be advocates. And that's what you were really talking about, being a self-advocate. We talk about it all the time. So thank you again. This was great.
Yeah, keep in mind, while we as physicians, we are busy, we have a lot on our plates and so forth. I will speak for myself. One of the things that brings me the most satisfaction is helping solve problems. So sometimes I think people don't want to burden us with something going wrong. And I would look at it almost the other way. Hey, if something's going wrong, even if you think, well, it's not that big of a deal, but if we can fix that, I feel better about it too. So you don't have to protect us from your your advocacy. We can celebrate those wins with you, even the small ones.
That's great advice, Nick. Thank you so much. And
Thank
it
you.
really speaks to the fact that, you get a diagnosis of Parkinson's, you're now a Parkinson's patient, and you need to know how to be a good Parkinson's patient. It doesn't come natural. Thank you so much, Nick. Round of applause. Thank you.
Thanks, everybody, and thanks for having me, Patrick, and board, everybody. Thank you.
Okay, so our next presentation is Dr. Jeffrey Wertheimer, neuropsychologist from Cedars-Sinai, and he is going to be discussing coming to acceptance with a PD diagnosis, how, when, if, and why. And I just want to say how great I think this whole day has been so far. So thank you, Jeffrey, for joining us today.
My pleasure. Thanks for having me, and I'll pull up my slides for everyone. First off, let me also extend the appreciation both ways, Patrick. So to Judy, Patrick, Natalie, to the board of PCLA, it's always a pleasure to be in my presentations to educate and support the community. And thank you all for attending, to the broader audience today, for taking the time. We take it sincerely. We're very sincere when we say we're grateful for your taking the time today to be a part of this as well. Lastly, I do want to thank my co-presenters, always great educators, truly inspiring content. And as a rehab neuropsychologist, you'll see some intentional kind of addressing similar content, but a lot of new. So let me jump right in. So I want to say, the topic of acceptance in Parkinson's disease, it's psychological heavy lifting, but I hope you'll enjoy the journey we're about to endure, if not experience together. Patrick, you said this just moments ago that really struck me. I was thinking about the journey of when do we manage the psychological response to Parkinson's disease, which predates the diagnosis, of course, but the diagnosis heavy, and then all the symptoms that continue to present itself thereafter. There's so much heterogeneity in the patient's experience with Parkinson's and the family system, but one thing that is kind of binding everyone together is that moment of diagnosis. Even if it seems uncertain, even if it's hard to believe, and I have patients that have shared with me in the past, it's kind of when you hear those words, you have Parkinson's disease, it can feel like the ground shifts beneath them. In many ways, it's like how they see the world changes instantaneously, and acceptance is almost an impossible word at some point. So today it's such a great topic, so thanks for the opportunity for us to go there. So I want to start off with actually a comment and then a few questions, just to kind of keep you engaged. I want you to think about these as it relates to you. Recall a time in your life when you were faced with a significant loss or change, and how did that reshape the way you experienced the world? It's important because we need to learn from our past. We can learn from our past and how that applies to the present moment. Did you accept during that process? Are we still struggling with the acceptance? What does acceptance mean to you beyond just how Webster defines it? How do you get to your own definition, and what does it mean to accept something? Is it challenging? Are you giving up, etc.? Are there times in your life where acceptance seems like it's just simply not possible, and now we're in a bind, we're stuck? And importantly, how do you cope with uncertainty? If not likelihood, if not probability, how do we cope with the inevitable that's coming down the road? So we have three main objectives. One, recognize the unique context of Parkinson's disease leading to the experience of grief and loss. Again, we can't talk about acceptance without addressing the loss, the change, the introduction to the unfamiliar. We want to explore meaningful ways of responding when acceptance seems to be out of reach. And of course, we'll hit this pretty heavily, identify adaptive coping strategies. That's cultivating resilience, but moving beyond just resilience itself, reclaiming purpose, rediscovering fulfillment. And I want to thank Dr. Keener too. She teed this up. She had such a marvelous presentation addressing the importance of, it's not just about symptom management, it's about how do we manage the lenses through which we see the world, using our resources, finding adaptive ways to live life beyond a disease that's so interfering. So starting with objective one, let's look at the context. So this is kind of the appetizer to the main course, if you will. Let's circle back to diagnosis. What is the psychological response to a Parkinson's disease diagnosis? It can be heavy and it can be quite varied, but we do know this. It's not uncommon, not universal, but it's not uncommon to have disbelief, a sense of denial, a sense of confusion. And it's not uncommon to use the ostrich method. Let's just bury your head in the sand and say, I'm not going to face this right now. An effective technique, by the way, temporarily for some. but sometimes it's not as effective as we want it to be and can do more harm than good. And then we have obviously the depression that can emerge, feeling demoralized, feeling that sense of stigma, that isolation, that no one else understands what we're going through for a person with Parkinson's and the family system. Feeling scared, having that fear, having the anxiety, of course, feeling paralyzed. I had a patient even just recently who was diagnosed with Parkinson's in her early 60s, and she and her husband had these grand plans of traveling, going to see parts of the world they always wanted to see, saving those moments post-retirement, and then everything stopped. In fact, they didn't feel like they could go travel, and they didn't. Everything stopped in the tracks, and then they became 100% focused on being a patient, not engaging in life outside of being a patient. And as Dr. Keener pointed out, there is an opportunity herein to live beyond symptoms and feel empowered, feel motivated, be inspired by the people who we come across in our support groups. Part of PCLA's big endeavor is creating space to connect, learn from each other, and grow. But then here comes context. It's beyond the diagnosis. Now we're grappling not just with the diagnosis, but the ongoing kaleidoscope of life that changes its dimensions seemingly every day. Hours and hours within a day seem to be different than the hours before. As Dr. Keener pointed out in a similar slide, but it's certainly worth highlighting again, when we're trying to accept a disease that continues to change its symptom manifestation with some consistent ones, i.e. the motor symptoms, tremor, rigidity, slowness of movement, gait, postural instability. But then you have what we call, non-motor symptoms. I remember Dr. Tagliati always would say, hey, this is a motor disease, but wait, it's a non-motor disease, having motor symptoms. The communication changes, the cognitive changes, psychiatric symptoms, sleep disturbance, fatigue, debilitating fatigue, autonomic dysfunction, even sensory changes. So how do we accept a condition that is such a thief, not just once, but over time? Life was so good before PD, so we have that remorse, that grief, that loss, the good old day bias, everything was perfect. Then we have the present moment, PD symptoms dominate life experience. And of course, we have that anticipatory grief. What is life going to be like for me in the future? Not a year from now, gosh, 3 months from now. So the research is clear, and I'm not going to spout out tons of research data, but I wanted to kind of show you trajectories. When we look at chronic health conditions, there are numerous articles that really spotlight this and say there are a variety of ways we respond. So if we say unique to everyone is symptoms of Parkinson's, well, how come the responses to those symptoms are so varied? We have some individuals with this innate psychological fortitude, this seemingly they're just robust in their resilience. Parkinson's disease can be traumatic for many. We don't talk about trauma in Parkinson's, but for many it is traumatic. But then their growth can occur from the trauma, even a sense of support. So you have this green line showing adaptive recovery from the diagnosis. We have the neutral group. They're just navigating the course the best way they can, not thriving, not getting worse, let's say, by psychological standpoint. And then you have the other path, counterproductive, it's maladaptive, or in this case, the unmet needs of treating psychological responses to such a challenging situation can lead to worsening health, both physical and psychological, which can lead to now non-compliance with medication regimens or engaging in those lifestyle medicine recommendations that we continue to receive. But I do want to spotlight even some that might have a challenging on the front end can rebound and robust over time, and the opposite is true as well. There's a clear pathway of those that start strong, but the unrelenting experience of Parkinson's symptoms can wreak havoc on the psyche, creating such a significant challenge to accept the condition and feeling caught and stuck in that adaptive response. So I put this out there just kind of as an image for all of you to embrace in some ways, is there is some consideration that as the intensity of the struggle increases, the acceptance of the condition, if not the symptoms around the condition, decreases. So there's a strong correlation. So in this case, the y-axis, greater sense of struggle, x-axis, the acceptance goes down. But is it about the external struggle, the physical demand, the internal struggle, the psychological demand, even the existential or spiritual struggles that we may have with a condition that seemingly is dominating our eyes? It's like a veil casting over our vision, and that's how we see the world at this point. So one more, a little bit of a context here. Coming back to that point of, we know that individuals, everyone attending today, have some connection with Parkinson's disease. So again, if context is in this box, How is it? Can't we just write a script and say, here's the pathway to accepting our condition so that we can move and thrive beyond it? But we realize it's not that simple. There's a broader context, maybe other medical challenges, maybe other psychological challenges, maybe other loss in our life of loved ones that have come to be. Or maybe it's far beyond that. It's other bigger picture context. And as psychologists, we can go to your childhood and talk about what framed your worldview even as an adolescent, young adult, and how that impacts our perspectives later in life. So with that, I take pause and I say, as we think about perception and as we think about accepting a medical condition, and maybe it's not the condition, it's accepting our response to the condition. We have to think about the frames that we see the world. One frame is this one. If I ask you, what are these two individuals seeing? It's very clear. This is what they're observing. Or is it really clear? Well, sometimes we say, I don't know. I can't make that out. Well, let's give another frame. Does this make it easier to understand? And yet another, I'm seeing something, I'm still not sure. And this came from an analogy of blind men grabbing an elephant. Well, if one grabs the trunk, they feel a snake. If one grabs a leg, they feel a tree. If another grabs an ear, they think it's a fan. The key element is sometimes we need to step back and look at all of the frames to understand, what are the strengths you possess? What are the core elements of your own resilience that will let you move forward with a psychological adjustment that is more favorable than challenged? And that takes a moment, and it takes a team. It takes perspective management. And I come back here to Dr. Aker's point. He has a great quote that says, hey, just like this model of the iceberg theory I'll show you in a minute, only 10% of our long-term happiness is based on the external world. 90% is based on how our brain processes the world. So in this case, said differently, I can know 100% of your surroundings. We could be experts in Parkinson's disease, but we still only know a percentage of your experience because it's about your perspective that's going to drive acceptance. It's going to drive the coping strategies chosen to adapt to challenges never fathomed before. So which takes me to this slide, and I know Dr. Keener kind of put this up there from another frame of mind, but I'm going to bring it from the psychological landscape perspective. You know, the tip of the iceberg is approximately 10 to 15% above water, meaning the vast majority of the iceberg is underneath. Well, that's where grief, loss, and fear exist. We can understand, of course, people have grief and loss when they have Parkinson's, but we think and we know it's much bigger than that. As Dr. Keener kind of highlighted, maybe it's about the loss of a relationship. Heavily, it's a loss of engaging in meaningful work sometimes, and paid or unpaid. Can't volunteer the way I used to. These core elements of life, giving to family, supporting friends, is now different. And that's a profound sense of loss that can be driving a big challenge of, how do I accept something that took so much from me and still does? We need to manage our perspective. And some of you know, I include this slide intentionally. What I'm about to say is not about putting rose-colored glasses on. It's not about saying, hey, just try to be positive. It's going to be okay. I will say, quite frankly, no. The idea behind perspective toward our suffering is not to say tragedy's good. I get to grow from this. Negative turns sometimes are just negative turns, and trying to be overly optimistic can be counterproductive. That said, a big takeaway is, while I'm not pleased with Parkinson's disease, I'm grateful I have the resources to navigate the course. We have outstanding resources in Parkinson's disease community, such as PCLA. We have other resources around the nation that have been really driven with great efforts to support our community, not just with education, but practical tips and good management of symptoms, and to move beyond just the management of symptoms, to really highlight where are we with living in a way that brings in hope, that brings in empowerment in a day-to-day basis. And that's what we're going to highlight in a few more slides. So with that, I do want to highlight Kubler-Ross's phases. Again, I'd be remiss if I didn't put a spotlight on this. Many of you have heard of Kubler-Ross, some of you may not, but it's a model of grief, and you'll see the far right acceptance. Interestingly, it was described as stages, meaning you go through denial, you experience anger, you're experiencing bargaining, you get depressed, feel hopeless, feel a little bit of hostile, and then you accept. But here's what we know in today's era, and I thought of Dr. Petrossian's talk when she talked about the fluctuating motor symptoms, fluctuating non-motor symptoms on a daily basis. Some patients say hour by hour. I thought the same thing about grief in the sense of loss and psychological adjustment. Here's the path that patients describe to me. They say, look, sometimes I can accept it 1 minute and then I'm right back to anger. Sometimes I accept it maybe at the 10th hour, but then I feel really low and overwhelmed and helpless. So it's not this clear pathway. There's a lot of fluctuation. But the key point is we can still get to acceptance. But what does that mean to you? So with that, I want to talk about this point. And I guess Judy and I were talking about this on a phone call about what is anticipatory grief? Because it's very relevant to our Parkinson's community. A lot of individuals with chronic illness, particularly when we know the symptoms can continue to change despite really good treatments. So defining anticipatory grief, what is it? Number one, it's emotional pain or it's mourning experiences before they actually happen. So anticipation of what's life going to be like for me in a year from now with Parkinson's disease. What are the symptoms are going to be there? I've talked to friends that have these symptoms, cognitive changes that are going to get worse. How do I navigate that course? So it's this concept of we see that there are tangible senses of loss, physical health, irrefutable, cognitive changes, yes. And the intangible things are a sense of fear of losing, loss of stability, the loss of even what is a healthy relationship now with a loved one, now is going to be more challenged. Our future dreams have been shattered because now I don't know how I'm going to manage Parkinson's. That shared experiences that we once had are now different. And who feels it? Not just the person with Parkinson's, but also those partners, the care partners, the family members, our friends can experience it along with our loved ones. And then I tie this unique element. What's different from grief, the conventional sense of grief, of loss right now, that profound sense of sadness, feeling overwhelmed, etc., is actually this mixture of not just this loss, but also this fear, this worry, this stress, and also the hope that still can exist with anticipatory grief. The hope that was given today about future treatments before that are actually experienced today. We still have that hope and need to hold on to that. So I mentioned care partners, and again, I could spend an hour on this in and of itself, but I want to highlight Parkinson's is indeed individualized. Grief and loss and acceptance is through the lenses of the individual, both person with Parkinson's, as well as through the eyes of the spouse, the care partner, the family members. So as Dr. Szumski pointed out, communication is really key. If it's on the mind, can we get to the communication? Can a person with Parkinson's talk to their spouse about their grief, their loss, their fears, their hopes, their wants, their needs? And similarly, can we have the spouse and care partner join the conversation and disclose their concerns? I will say openly, and I can imagine what's going through some of your minds, we can't talk about it because we don't want to be a burden on our loved ones. If we share these thoughts and concerns, it may weigh heavily on their minds. True, and it could, and often does, but it doesn't make it insurmountable. That's merely a gateway to having a conversation that goes unspoken. And maybe that's part of the healing process. When we can't find the cure, we can still find ways to heal. And talking about grief, loss, and acceptance together can be very, very powerful. So as we segue, I want to highlight this juxtaposition of grief and adaptation, from relearning the world as we know it, from despair to hope, to lack of understanding. The unfamiliar is so pronounced, but can we gain insights to find meaning, to find purpose that was usurped once Parkinson's came into the picture? That bodily discomfort that's constantly there, how do we reintegrate a mental, in this case, mind-body connection to help us adapt? And that leads us to objective 2 and 3. How do we explore meaningful ways to respond when acceptance feels just out of reach? And how do we implement adaptive coping behaviors? Cultivating resilience, yes, and moving beyond that to reclaiming purpose and rediscovering fulfillment. So I want to highlight this. Let's focus on these few questions. 1, how do you cope with loss, stress, and the uncertain? How have you? How do you now? What does it mean to be resilient? And I really appreciate this statement that the absence of disease is not health. So as many of us will talk about and promote, while we try to manage our symptoms of Parkinson's disease, trying to manage the lifestyle medicine approach, managing perspective inside of lifestyle management is really critical to reaching healthier moments. And how many have you been asked this before? What fulfilled you today? That's not a question we often ask, but how great would it be if we could identify, this is how I felt satisfied, more than satisfied, this is how I felt fulfilled. In this case, Dr. Szumski even highlighted, he loves it when patients ask him questions. Why? Because he loves problem solving with partners. So with that, keep asking the questions, creates fulfillment for your physicians and treatment providers. But how can we do the same for you? Brief snapshots for time. Resilience, simply defined, absorbing strain, bouncing back, learning and growing if possible. I have patients tell me I'm exhausted from being resilient. Resilient is hard work. I wanted the paradigm shift to be, let's move into a model that creates adaptation with sense of fulfillment. Finding sense of achievement, as small as it may be. We don't need to get a name on a building. We can have an act of kindness that does a good gesture to another person. Aligning our action with our values, finding meaning in our day, in our moment. Serving, giving back, again, can be a mechanism, just giving a sense of appreciation, a comment of gratitude, feeling valued internally and externally, and of course, trying to get to fulfillment. So this is new, and I want to really pause for a minute. So some of you may, I would say, just out of thought process, many of you haven't experienced this framework before. Some individuals try to manage grief. We need to minimize it. How many of you have heard, just get over it, cheerleading, hey, you can do this. Grief is there. We will work through this together. We try to live life with grief coexisting, but importantly, here's the model. Let's shrink the grief. We're trying to reduce grief, get rid of grief so we can live life fully. I want to have a paradigm shift with you today. Challenge the old idea. It's a myth that grief shrinks over time. It can. Healing can occur where grief tends to get smaller, but actually, what may be happening is that life is getting bigger. Life expands around the grief. So in other words, we make space for it. We don't need to try to force it out of our lives. Differently, we learn to grieve, let it coexist with us. It's like a pearl in an oyster. That sand is really painful. We morph it, I should say the oysters do, so it has a smooth exterior, and now it coexists with the oyster. The oyster can still live with less pain. That's how we want to adapt, is allowing new experiences to grow, still living for joyful moments, permitting growth to happen, integrating this lifestyle experience with grief, but importantly, living more fully. And I'll segue to a few more points, and we'll get over to Dr. Tagliati in just a minute. But I want to highlight this point. The power perspective. I've always loved this quote. I integrate it into presentations. Individuals with chronic illness, often many people with chronic illness, may become trapped and invalidated, not by the disease itself, but by the power of the beliefs about it. If that is true, there's some healing that's accessible now. If it's about our perspective, let's do it. Let's try to manage our perspective. But can you? Can you manage perspective? Is it even possible? Well, Viktor Frankl, many of you know that. I reference him often. He's a psychiatrist by background, has merit to his words. He lived through 3.5 years of being in the Holocaust, including Auschwitz. And he made this statement: when we're no longer able to change a situation, we're challenged to change ourselves. That's powerful. But can we? Can we challenge our own perspectives and modify how we see a situation that seemingly can't change? So can we? Can you manage perspective? In cognitive behavioral therapy, 2 years ago I presented this, by the way, just these 2 slides. I want to throw this your way. We have automatic thoughts. They happen very quickly. So if I put an image up on the screen, what do you see? What's your first thought? What comes to mind? Okay, some of you are jumping on it. It's a horse. As long as we all agree this is only a horse, this is the only way to see this image, we will not have conflict in this room. Until we say, wait a second, someone else is thinking, I see a frog. Everyone else is hearing me say that, and you're saying, what are you talking about? There's no frog, there's a horse. But here's the challenge. If I challenge all of you, can you see life differently? Of course I can. Can you see this beyond the horse? Let me help you. Here's the head of the frog. Here are the hind legs. So it is true. Sometimes I need help though. I need to change my vantage point 90 degrees. I need to step back. You know what? I need help. I still don't see the frog. How do I get there? Let me walk you through the image. That's the power of managing perspective, is realizing that you can. Viktor Frankl, again, by his own merit, says everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way. So I say this humbly. I'm not comparing anything to living through the Holocaust, not at all. But what I will say is when a person of Dr. Frankl's stature can say, stripped of everything, his wife passed away, he lost his unborn child, he lost everything a human could want, liberty, except he can manage his perspective. But how does one do that, even with Parkinson's? Here's a brief tool, Cognitive Therapy 101. Okay, hang in there. Situation. is this. We're not talking biological changes to psychological health. What we are talking about is our ability to manage perspective through our own efforts. Situation, due to Parkinson's, I can't work anymore. I can't help with home responsibilities. Fact. No, it's irrefutable. These are situation, it's a fact. But what's my response? I'm grieving, I'm in pain, I feel depression, I feel guilt. Here's the model. Fact, I'm unemployed and I can't do what I used to do. My thought is, now I'm a burden to my loved ones. It's straining my relationships. My symptoms, this conversation, the center of all my conversations, that's driving the feeling of grief, depression, and guilt. Can we see that differently? Situation's the same, but can I alter my thoughts? Well, you know what? Even with PD, my family's really stepped up. My community's been there for me. PCLA on amazing forums. I can support my family by how I respond to it. I have the capability to still nourish my relationship, which leads me to, I feel hopeful, I feel empowered. It doesn't make my grief go to 0. It was a 10 before. My depression, my guilt was an 8. But now it's a 4 because I let hope in. I let empowerment in. That's how we manage perspective and manage our sense of grief. So with that, a couple key points, and we're wrapping up in a minute. It's a busy slide, but I want to highlight, this is some work I've done back in the early mid 2015, 16, 17, published 2019, and importantly, Dr. Asher and I, colleague physiatrist, and I published a paper in 23 highlighting that this model works. On the bottom right, you're going to see a key. The purple's the most robust pathway. The green is an adaptive pathway, but not as robust. The red hashed is a less effective approach to coping. So you have a stimulus, it's going to drive a response. Those 3 bubbles. You're going to have a cognitive or thought process response. You're going to have a behavioral response. You're going to have an emotional response. Out of those, this is what the research is really clear. When we manage attitude, when we live in the moment in a mindful way, not judgmental, not critical, open with curiosity, with wonder, when we problem solve, just as Dr. Szumski said, when we engage in that problem solving technique, and when we validate our emotional state, that will build self-confidence. That is what we found. More than just being resilient, it created fulfillment. The green, distraction, self-soothing. How many of you have watched Netflix just to get away? Don't raise your hand. We know some of you have. How many of you walked outside to feel the sun in your skin just to take your mind off something? Yes. Very powerful, but temporary. We need to circle back to the purple. And lastly, rumination, avoiding maladaptive coping behaviors like is alcohol consumption, smoking, just as a mechanism of coping, can be counterproductive to health. So now we have the equation to better is attitude, mindful, task-oriented behaviors, and validating our human experience. All very critical to health and wellness. So with that, I'm going to segue here just briefly. Shawn Achor, I shared that quote with you from him before. I want to highlight, we know there's an algorithm now for health and wellness. Managing acceptance is part of these core elements. We can't be grateful for every moment, but you can be grateful in every moment. Key quote. With that, practicing gratitude every day, journaling, not just the challenges, but the success stories, what was inspiring for us. Exercise. Dr. Tagliati is going to give you a whole lecture on that. It's brilliant. It's fantastic. I'm going to go out there and say exercise physically, exercise psychologically are both critical. Mindfulness moments and intentional, deliberate acts of kindness. If we do those every day, believe it or not, we're on a pathway to acceptance of our response to life. It's powerful. So I'll leave you with a quote, then we'll get to our takeaways. A single footstep will not make a pathway in the earth. Still, a single thought will not make a pathway in the mind. To make a deep physical path, we walk again and again. To make a deep mental path, we must think over and over the kind of thoughts we wish to dominate our lives. This is neuroplasticity, neuronal connectivity. It's also psychologically powerful. Think over and over the thoughts we want to dominate our lives so we can get to that acceptance. Because we keep seeing Parkinson's dominate our worldview, it's going to be very hard to accept something that's taken so much away from us. But if we see that we still can live life, engage in life, fulfilling, in a fulfilling way, it will be a game changer for acceptance. That said, here are three takeaways, 2 action items per request of PCLA. Number 1, you're not alone. We want to emphasize that point. That's critical. 2, your takeaway today is this: redefine acceptance for you. It's not about accepting Parkinson's disease. That can be for some. It's about accepting that we have a response that we can have. We can be responsible for living in a very adaptive way. That I can accept. I have more control than I gave myself credit for. And lastly, practice small acts of agency. That's what you keep hearing from all of the physicians here today. If we empower ourselves to take action, it can make changes. But it doesn't have to be profound. We can enjoy nature, that's action. We can connect with a friend, that's action. We can deliver a smile to somebody else, that's action. We can do something creative. Again, PD doesn't define our whole story. You're the author, you're the narrator, managing the words in your chapter, in your paragraph, in your sentence. Let's find a way to gratitude and acceptance in a way, but important, let's realize life is much more than Parkinson's. It's about being with each other and finding ways to have fulfillment in each day. So with that, I thank you for your attention, and I will open the door. Patrick, Judy?
Thank you so much, Dr. Wertheimer. That was, we were all expecting, poetic as well as informative. So thank you, thank you, thank you. Judy, do we have some questions or comments?
We don't have anything in the chat right now, but I think people need to kind of resonate, what is the word? Ruminate with this. I love it. I think we need to think about this. It was fantastic. Thank you so much. And I really appreciate your time in doing this.
You know, one of the topics that has come up on my online community is exactly what you said, is that the power of positive thinking is so helpful, but you hear those cliches, you just got to stay positive, which is completely not actionable. So thank you for giving us a pathway into making arriving to a better place actionable.
Yes.
Thank you so much.
Thank you so much.
All right. So yes, a round of applause. Yes. Okay. So our final discussion here is Dr. Michele Tagliati, neurologist and movement disorder specialist at Cedars-Sinai. And he's going to be talking about beyond, I love this title, Beyond Rehabilitation, the role of exercise in preventing, modifying, and mitigating Parkinson's disease. Welcome, Dr. Tagliati.
Thank you, Patrick, and thank you, Judy and Natalie, for inviting me again. It's always a pleasure. The last lecture, I don't know if I should say good morning or good afternoon, is going to be about exercise. Exercise, we always hear about it. I wanted to put it together in some perspective and give you some takeaways at the end about the importance of exercise. And let's see, there you go. The role of exercise in Parkinson's disease goes back a long way, actually more than 100 years ago, actually 200 years ago now, when Dr. Charcot was a legendary neurologist who actually defined the term Parkinson's disease to honor the original description by James Parkinson. Dr. Charcot was a brilliant man, and he noticed that patients with Parkinson's disease seem to sleep better and have less symptoms after a carriage ride. So he put together this vibratory chair, and he had this 30-minute session on this vibration chair every day. I mean, to be fair, reading the reports, it didn't have too much sort of success with that, but one of his fellows and colleagues, Dr. Gilles de la Tourette, which gave the name to the tic syndrome, right? The Tourette syndrome, actually put together this funny helmet there because he thought that the vibration should be actually applied to the head, to the brain right away. You can see a little bit of a crude methodology, but this is the first reference to exercise, to movement that we can find in history. Fast forward 200 years and to 2008, when we can find, believe it or not, the first sort of organized paper summarized the support for exercise as a beneficial practice for Parkinson's disease. And as you can see, as of recently as 2008, only 14 studies will qualify for a review. The number of studies has more than tripled ever since, as we will see together. And even though there was some evidence supporting exercise, there were more questions than answer about the optimal content and intensity of exercise and the different stages of the disease that exercise might benefit patients. So let's take a step back and let's define. Many of my patients, ask me, but just having, working around the house, so what we would call physical activity, is enough, or do I have to go to the gym and actually start an exercise program? Well, let's define these two entities. Physical activity, by definition, is any movement of the body produced by your muscles that will result in some caloric expenditure, some energy expenditure. And it can be anything from household activity to formally organized sports, or just go to work. Some people have very physical works that can count, obviously, for energy expenditure, or just do conditioning, sort of light physical activity. Exercise is a subset of physical activity, which is defined as voluntary activation of your muscles, which result in a movement of the body, of course, which is, however, planned, structured, repetitive, and with the purpose of improving or maintaining physical fitness. So exercise is part of physical activity, but it's a much more structured and repetitive activity, which obviously tries to obtain certain physical advantages. In reality, this is very important, and not just because, as we'll see, it can provide some benefits, but because the very essence of Parkinson's disease, the symptoms of Parkinson's disease, both motor and non-motor, we will see, could be due to the disease process, the loss of dopamine neurons, or whatever else is happening in the brain, but also to the reduced physical activity that is unfortunately associated to the progressive nature of the disease, and more likely to a combination of the two. So physical activity is not just some addition to treatment, as we will see, but it might be an essential point of the severity and the progression of the disease. And something that is not well investigated, well studied, is whether physical activity, again, household chores, or going to a physical labor and specific exercise, have comparable effect. And again, even if it's not studied, there is a consensus that as long as it's moderate to vigorous physical activity or moderate to high intensity exercise, they pretty much elicit comparable effects. So as long as we do it seriously, as I like to say, if we sweat it out, both physical activity in general and specifically exercise may have comparable and, I would say, beneficial effects in Parkinson's disease. Most importantly, and this is something that I also get asked quite often, is it safe and is it even possible to do exercise if you have Parkinson's disease? And the results from available studies is quite supportive and optimistic. Exercise is generally considered safe and definitely feasible based on a number of studies that reported very, very few numbers of adverse event. Actually, 3 out of 4 of studies available did not report any adverse event. And those who did report some problems, like transient pain or inflammation of the joints, dizziness, tiredness, maybe some falls or worsening of some pre-existing injuries, were never, did not result in a higher number of dropouts. Actually, the dropout rate of those subjects that were randomized to perform exercise were less, paradoxically, than those who were not exercising. So those who were exercising were staying in the study more than the control arm, as you can see, 8% versus 11%. And in fact, in general, in studies dedicated specifically to Parkinson's disease, there's a very high compliance, a very high completion rate. You see over 90%, so 9 out of 10 subjects completed the study. So exercise is definitely safe and feasible in Parkinson's disease. So, and what can exercise do to you or to your body? Well, 3 basic things, and we're going to look at them in details. And this is very important because it sort of involves the population, and especially the aging population at large. So primary prevention is the protection against disease development. In other words, reduce the risk of getting PD to start with. Secondary prevention is slowing the disease progression. So once the disease is diagnosed, try to slow it down and to modify the inevitable progression. And what we call tertiary progression is the symptomatic exercise as a symptomatic treatment, because as we will see, exercise seems to have effects that are overlapping, if not sometimes superior to those of Parkinson medications like levodopa and other dopaminergic treatments. So let's look at these 3 aspects of exercise, and this is what is known, what the science is bringing us. So let's start with primary prevention. So it's been now several years, as we've seen, at least the last 2 decades, that physical activity and exercise has been studied as modified protective lifestyle factor. The studies have now involved a very large number of subjects, over, you see, 500,000 in some studies. And the results show quite conclusively that people that are engaged in high levels of moderate to vigorous physical activity in middle or later life have a lower risk of Parkinson's disease. And I'll show you some graphs about it. And there are several studies, several reviews that show this with criteria of causality. This is not just a chance. The consistency of the findings, the strength of the statistical associations, the temporal sort of association between exercising and certain benefits, those response effects, meaning the stronger is the metabolic involvement, the metabolic expense, the highest is the intensity of the exercise, the lower is the risk to develop Parkinson's disease. And in general, the plausibility biologically that exercise can positively affect our body function. There you go. This is one of the graphs. I didn't want to weigh the presentation with too many graphs and numbers, but this is quite interesting. And you see that both total physical activity on the left and moderate to vigorous physical activity, which however has a much steeper curve, which means that the effects are more likely. You see, with moderate to vigorous physical activity, we can reduce the risk of having Parkinson's disease by 60%. That's an enormous reduction of the risk. To put it in simple words, if the general risk with age of developing Parkinson's disease is about 1% per year, which would mean that unless there are specific genetic or environmental triggers, it might take many decades to develop Parkinson's disease. You have to get into your 120s or 130s to develop Parkinson's disease. With physical exercise, we can make that virtually impossible to develop Parkinson's disease. The risk will become so low that in a normal life length, it would be virtually impossible to get Parkinson's disease. So this is extremely important and extremely encouraging. And even if you see on the left, total physical activity has a dose response. So see, the higher is the metabolic intensity of the exercise, the higher is the reduction of the risk of developing Parkinson's disease. And this is sort of a graphic representation. You see, we have the neurological decline. In the blue is people that have regular lifelong exercise. In the green, those who exercise after receiving the diagnosis of Parkinson's disease. In the red are people that sort of do nothing about it. And in the black, the idea that lifelong exercise may actually prevent completely the development of the disease and sort of ensure a long-term life without neurodegeneration. Secondary prevention. Secondary prevention refers to exercising after a diagnosis of Parkinson's disease is already been established. And it's never too late, as we will see, because exercise has been shown to potentially modify the underlying pathology of the disease, slow down the progression, and possibly also create what we call a neuroprotective treatment. So protect the neurons, the brain cells, from getting Parkinson's disease or other neurodegenerative processes. Most of the evidence supporting this idea originates from Parkinson animal models, which is in part the problem because, as you might know, animals do not develop Parkinson's disease or neurodegeneration in nature. So these are all intoxication, basically artificial intoxication, trying to reduce the number of their dopamine neurons or other neural functions. So much of these results have to be taken with a bit of a grain of salt. But there is also data in humans, and even if it's limited, it shows quite encouraging data. For example, improving the strength of your lower extremities, of your leg strength, is inversely associated with the UPDRS scores. As you know, the UPDRS scores is a way your neurologist can sort of quantify the severity of the disease. The higher is the score, the worse is the disease. And so improving the strength of your legs has been associated with reduced MDS UPDRS scores and therefore better Parkinson or less Parkinson. Similarly, increased physical activity has been associated with the slower deterioration of activity of daily livings, posture instability, and gait disturbance. And this is particularly important because very often poor balance and problem with gait are refractory to medications and to levodopa in particular. So exercise might provide a level of treatment that medication per se fail to give. Another point, again, is that higher intensity of exercise seems to be more effective than moderate intensity and obviously no exercise. How do we define higher or lower or moderate intensities? Based on the so-called maximum heart rate that can be calculated, subtracting your age from 2020 and then calculating about 80% of that. So depending on your age, the 80% of maximum heart rate is somewhere between 120 and 130 beats per minute. So something that can definitely be achieved, on a stationary bike or with a fast walk. Resistant exercise, so not only aerobic exercise, but also resistant exercise can improve the severity of Parkinson's disease, but also cognition. We'll get back to that. And this is one of the takeaways. There is no association between the baseline physical activity, so where you start with your fitness, and the clinical progression of Parkinson's disease. In other words, it is never too late to start exercising. So this is a very, very important take-home message. It is not too late to start exercising if you have a diagnosis of Parkinson's disease, or in general, if you are at an age that would present a risk for neurodegeneration. These are some more specific studies. These are what we call a meta-analysis, which is an analysis of many different studies. And it's regarding motor symptoms, shows that all exercise modalities, so aerobic, resistance, general activity, can impact positively walking capacity, postural stability, balance, and the UPDRS-3 scores in general. And if you look at these graphs, it's very important that you see if the lines go toward the left, it favors basically no improvement. But if the lines go to the right, it means that they favor exercise in favor of patients with Parkinson's disease. And you see that most of the study, if not all of them, with a few exceptions, seems to go toward the right. But most importantly, you see I put here a red an arrow, which says levodopa effect. So this is the expected effect of levodopa. Many of these studies went well beyond what the normal expectations from our current medication can provide. This is amazing, because it means that levodopa is not the end of all. We can definitely supplement the medication effect with exercise. And in fact, I found a note that says the size of the effect, especially in balance and mobility, range from similar to superior to the reported improvement of levodopa on balance and mobility. So exercise can be superior to levodopa in a specific part of our motor function. And not just motor function, but also non-motor symptoms. For example, cognition, sleep dysfunction, quality of life seems to be improved by all exercise modality. In fact, physical inactivity has been associated with worsening cognition. And so it's important to, again, remember and take home the message that engaging in any type of exercise can help both motor and non-motor symptoms of Parkinson's disease. And so let's go back to our sort of conceptual representation. Again, the black line up here is people that, thanks to lifelong exercise, never develop Parkinson's disease. Then there are people that receive a diagnosis of Parkinson's disease. You see the D, and regular exercise prevent much of the neurological decline. It makes the non-motor and motor symptoms much milder than those that start exercising after the diagnosis, which still have a positive effect compared to traditional Parkinson course without any type of exercise. And obviously, quality of life also benefit from that. Regular exercise has a higher quality of life compared to no exercise. Why do we see this is actually still a bit of a question scientifically. The effect of exercise, the exact effect of exercise on Parkinson's disease and the neurodegeneration are still quite unexplored. Again, many of the studies are on animal model with the limitation that we discussed. And also, part of the problem is that some of the effect may benefit the patient with Parkinson not only or not specifically for specific neurological or neuroplastic effect, but it may be a broad spectrum effect on many other organ system, cardiovascular, for example, circulation, digestion, that may contribute obviously to the improvement in the quality of life of a patient diagnosed with Parkinson's disease. There are some theories that neurotrophic factors might be involved. There is some data that show that the cognitivity between different parts of the brain seems to be better after exercise. There is less brain atrophy. That is something that unfortunately happens in all of us with age. So exercise is definitely something that has been shown. In preliminary study, I have to say, there is no conclusive evidence to basically improve not only the function of the brain, but the function of the entire body. And in fact, there is a lot still to do. This is a pretty busy slide, so I spent 1 minute to go through it. These are all the sort of research gaps. I mean, there's a lot that we still need to know about exercise. We're still not very good at quantify physical activity, right? It's difficult from individual to individual to exactly measure how much physical activity everybody is able to do. In terms of secondary prevention, it's difficult to assess disease progression, which is different from person to person. So is the exercise really helping, or are we dealing with a type of Parkinson that would be milder in and on itself? We need larger studies. And in terms of tertiary, in other words, symptomatic effect, we need to be able to quantify better certain motor symptoms and non-motor symptoms like fatigue, cognition. Look at different type of exercise head to head and see which one is the best type of exercise, if any. Include other quote unquote exercise modality like dancing or Tai Chi or boxing, you know, sort of a less structured type of exercise. We need to do, as we said, a lot of research on underlying mechanisms, but we can say that we should study how implementing early exercise treatment, how support people with Parkinson's disease so that they can continue exercising long term, even when the disease starts causing disability. Very importantly, we need to evaluate and quantify the cost effectiveness of exercise. Is it going to be cost effective for an insurance company to pay for a gym subscription for a patient early in the disease to save a long term on the cost of disability in these patients, and obviously promote collaborative approach between physician, physical therapist, maybe experts in exercise plans. These are all questions that are only intuitively answered. We all think that obviously there is a cost effective of exercise, but have not been quantified precisely. So we're talking about a paradigm shift. We need to prescribe exercise as early as possible in tandem, not as alternative to pharmacological treatment. We need to individualize training program based on the stage of the disorder, comorbidities, personal preferences. There are people like running, other people don't like running. We need to take that into account to maximize compliance, of course, the basic level of fitness. And so we need to stimulate a multidisciplinary approach, something that we are already pursuing at Cedars-Sinai with our multidisciplinary clinic, with the physical therapists, speech therapists, occupational therapists, behavioral therapists like Jeff Wertheimer. And also we need to start thinking, and we didn't talk about that, but we need to start thinking to prescribe exercise for those who are at risk of developing Parkinson's disease. Maybe they have a familiarity, some genetic variant or REM behavior disorder, loss of smell, other symptoms that we know they are associated with the very high risk of developing Parkinson's disease, to delay maybe the time of diagnosis and reduce that risk. So conclusions, takeaways, exercise. I think I demonstrate, or there is enough information to demonstrate that exercise may prevent in some cases, modify, but also mitigate Parkinson's disease. Sometimes exercise can be better than levodopa for certain symptoms. Exercise should be therefore viewed as prescribed medicine, not just as some, ancillary activity that we can do sort of at our leisure. Paradigm shift, we discussed how we should start early exercising in Parkinson care using a multidisciplinary approach. There are major research needs also because we don't fully understand and therefore control the pathophysiological mechanisms, the specific effect that exercise bring, as I said, not only to the brain, but also to the rest of the body. So I'm gonna leave you with my arrival photos at the Los Angeles Half Marathon, trying to lead by example. And want to thank all my colleagues at Cedars-Sinai. You may recognize some of them: Dr. Bordelon, Dr. Malad, Dr. Ten, Dr. Hogg, our surgeon, Dr. Mamalak, and all our supportive foundations. And obviously, Parkinson's Disease for Dummies is my small contribution to the literature. Thank you for your attention, and I'm going to be here if there is any question.
Thank you so much, Dr. Go ahead, Judy.
No, I was just going to say I'm looking in the chat right now, and there's a comment here from Robert Lavore that says that his neurologist once told him the proper approach to PD exercise is to work out until you are totally exhausted and then do another set. I often can't tell how to judge this if I'm in an off condition. This is like our only question we're going to have time for, but if you can just do a quick little bite to this.
Yeah, this is a very good comment, actually. And this is one of the points that we still struggle a little bit. We know that the high intensity or moderate to high intensity of exercise seems to be more effective than mild exercise, obviously, or sedentary activities. But exactly what that means is a little bit challenging. We saw the 80% of maximum heart rate, which is definitely an interesting metric. But personally, I would not encourage people to get exhausted. Getting exhausted is probably a form of stress. It may also, at least in the short term, make you feel worse. I would definitely, some of the available clinical trials, control experiences seems to prescribe 30 minutes of moderate to intense exercise, at least aerobic exercise, 4 times a week. So every other day, more or less. And I always personally, empirically, recommend not to have only one type of exercise. Would that be aerobic or resistance or strength or stretching, but try to mix and match all of them in order also to sort of vary the experience and not, get dogged with the same type of exercise every day that can get maybe boring and decrease compliance. So don't go crazy. I would say a point more, I would focus more on the long-term diligence and persistence and compliance with the exercise regimen than to try, as I like to say, being a marathon runner, to go and run the New York City Marathon next week. That would be probably even dangerous or counterproductive.
Thank you. I do have one. I think that this is, there may be other people that question this. The difference between physical therapy and exercise for PD.
Very good point. So physical therapy is also, because we just said that exercise can be a therapy, right? So technically they're both therapies. Physical therapy, at least in my mind, is more something that we prescribe when we have a fairly defined problem, for example, freezing of gait or problem with balances. There are a lot of amazing strategies that our physical therapists can put in action to teach or relearn from the patient side a certain basic mechanism of walking and agility. Well, exercise is more of a sort of less structured activity that someone can put together by themselves, or maybe with the help of some gym, a professional, but not specifically to treat this or that abnormality that has occurred as a consequence of Parkinson's disease. At the end of the day, they can be very similar, but physical therapy is more structured and defined to specific symptoms. I think physical activity and exercise is more of a general, almost lifestyle change that I encourage all my patients to pursue.
Thank you so much, Dr. Tagliati.
Patrick, do you agree? I mean, you're
yeah. So when I first started this, they used physical therapy and exercise interchangeably 20 years ago, whatever. But physical therapy, I've found it's like the acute management or treatment of a specific issue. Like if you have a knee replacement, you go in for physical therapy. Whereas if you go in when you have Parkinson's to a physical therapy studio and you don't have something specific like that, they're going to give you exercise. They're going to either use the LSVT Big program or the Power program by Becky Fowlerly, which is a great program. So yeah, you answered it pretty perfectly.
Great.
Yes. So thank you so much as always, Dr. Tagliati.
Thank
Wonderful
you.
Presentation. Thank you. Okay. So Dr. Wertheimer mentioned how many wonderful resources there are now available for Parkinson's, and mentioned how PCLA is indeed a wonderful resource and support system for families living with Parkinson's, and we couldn't agree more. And as I said at the top, our desire is that you'll leave today with a perspective that allows for a little more hope and a little more joy, and that the metaphor of life's garden of hope and joy grows for each one of you. So thank you so much to our wonderful medical advisory board and presenters. What a truly unique and informative presentation, just seeing the comments on the side here. I want to again extend our gratitude to our partner, Acadia, and of course to all of you. We like to think PCLA's mission, tone, and style are unique. And if you enjoyed today, please make your tax-deductible donation by scanning the QR code or by visiting PCLA.org so we can see you here again next year. We really depend on your donations to keep going. We have wonderful plans for 2026, including more fun in-person events throughout the greater Los Angeles area, new support groups, and new online programs to help you live your absolute best life. Thank you again to everyone who attended, and from all of us at PCLA, have a joyful rest of your day.
Thank you all.